đó, ngoài cái Good morning, everybody. Welcome to this second day of this exciting conference. We're looking forward to another great day of interaction. I would like to thank the speakers for inviting me as a session chair in this first session of the day. My name is Heila Platz. I am an anesthesiologist based at Sefako Makgato Health Sciences University and Dr. George Mukari Academic Hospital in Ga-Rankuwa near Pretoria in South Africa. So the first talk, none of the speakers in this session really needs much introduction, and I'm very pleased to ask Dr. Meseret Gebre to be our first speaker. She will be speaking on clinical research ethics. She is a pediatrician that's been working for more than 10 years as a clinician, a clinical researcher, and a trainer at Armauer Hansen Research Institute in Addis Ababa in Ethiopia. Speaking with her is Bruce Picard. As you know, he is a proponent of international collaborative research and has been leading the ASOS2 trial and the ACOS studies through the collaboration with the African Perioperative Research Group, or APORG network. So I'm very happy to introduce these two speakers to you to talk about clinical research ethics. Thank you.
Okay, good morning. My name is Meseret. I am a pediatrician and a researcher working at AHRI. In this session, we are going to talk about clinical research ethics. So the outline of my presentation will be, we'll have a brief introduction. We'll see into the historical accounts of some important ethical breaches. We'll see the ethical requirements of clinical research, responsibilities of researchers and scientific misconduct, and we'll have a summary. So what is ethics? So ethics in the context of clinical research is about the norms, values, what's right, what's wrong, or what is good or bad, and what we ought or ought not to do in the context of clinical research. So these are a set of norms which we need to apply while doing any clinical research. So why do we need research ethics? So the main purpose of a research is to get a generalizable knowledge on a certain topic so as to improve the health of a society. So it's important, it adds value to the society. But in order to do that, we need to involve research participants. So while involving those research participants, it's important to respect their safety, dignity, and autonomy. That's why it's important to have ethical guidelines. So while we are trying to get some generalizable knowledge, we are approaching some few individuals to get involved in certain research, and they are asked to accept some burden or risk in order to benefit others and society. So while doing so, there are risks for potential exploitation or abuse of such human participants. That's why we need research ethics. So coming to some of the remarkable historical ethical breaches in the past, though there are quite a lot of them, there were two remarkable or influential ethical breaches, which has led to development of different research codes and guidelines. The first one is the Nazi experiments, which was done on prisoners of war, and which led to the Nuremberg trial and Nuremberg Code. in 1946. The second one is the Tuskegee syphilis study. So the Nazi experiments included different experiments. Their intention was, one, to facilitate survival of their military personnel. As part of that, they did different experiments, like high altitude experiments, treatment for hypothermia, and making seawater drinkable. So they did these different experiments on the prisoners without any consent or agreement by the participants. They also did different drug and treatment studies to treat different illnesses such as malaria, TB, and typhoid, which had affected their military. They also did sterilization of Jewish and Roman people. So these were very unethical research experiments done on prisoners. The second remarkable ethical breach was the Tuskegee syphilis study. This syphilis study was done in Tuskegee, Alabama between 1932 and 1972. So the objective of the study was to study the natural history of untreated latent syphilis. They involved more than 400 black men with syphilis, and there were around 200 without syphilis who served as controls. So during this study, there were a lot of ethical issues. One is the participants were not given adequate information, even they were misinformed, that they believed that they were getting free treatment. They were misinformed that the spinal taps were meant for therapy, but that was not the case. And this study just continued. And the participants were not offered treatment when penicillin was discovered in 1943. It was discovered as treatment for syphilis, and people were getting it, but these participants were not allowed to receive penicillin, and they just continued the research. So in 1972, press reports caused the US government to stop the study. So this was also another very important historical account of ethical breach. And as a consequence of such ethical misconducts, different ethical codes and guidelines were developed to list the main ones. Nuremberg Code, this was developed as a result of the Nuremberg trial of the German physicians who were involved in the Nazi experiments. The other is the Declaration of Helsinki by the World Medical Association. Other guidelines included the Belmont Report, SEOMS, and the US Common Rule. So, though there are different details in these guidelines and codes, they revolve around these three key ethical principles. So the first one, while we are thinking of any clinical research, we have to adhere to these key critical ethical principles. The first one is respect for persons. So individuals must be treated as autonomous agents, and those participants with diminished autonomy must be protected. Their rights must be protected. The other important ethical principle is beneficence and non-maleficence. This is about doing no harm, and also we have to maximize as much as possible the benefits and minimize possible harms or risks to participants. And the other key ethical principle is justice. So we have to be fair while selecting participants for a research. So all individuals must be treated fairly while carrying the burden of the research and also benefiting from the research. So coming back to these ethical principles, we apply these ethical principles as we apply a respect for, we show our respect for persons mainly through informed consent. So we have to respect their autonomy by getting a valid informed consent. Beneficence is assured through a critical risk-benefit analysis so that we can maximize the benefit and minimize the risk to the study participants. And justice, while selecting study participants, we have to be fair in the distribution of burden and also benefit from the research. So to see in more detail of the ethical requirements of clinical research, as you know, the main goal of ethical guidelines is to both to protect the study participants and also to preserve the integrity of science. So in order to assure that, there are different ethical requirements of clinical research. There are 7 ethical requirements. We'll see each of them in more detail. So the first one is value. For a clinical research to be ethical, it should have a social or scientific value. It has to have a goal to improve the health and well-being of a society or increase scientific knowledge. So the main reason why we need to have such social, scientific, or clinical value is to avoid exploitation of study participants. We need to protect study participants and avoid their exploitation. And also we have to be responsible while using the limited resources we have. So for such reasons, it's important to have value. The other is scientific validity. Always while doing any clinical research, we have to do it in a methodologically rigorous manner. And in order to have that methodological validity, we need to have a valid research design for the research question we are going to answer. And the research should be conducted carefully and accurately in accordance with the design we have proposed. So even though some people think that science is not related to ethics, but it is, poor science can be equated, or it's said to be equivalent with poor ethics, because if we have poor science, then participants will be exploited and exposed to unnecessary risks, and also we are going to waste the limited resources we have, which we could have used to other important research questions which could help the health of the society. So scientific validity is also very critical in terms of ethical clinical research. The other is fair selection of participants. So while thinking of selecting study participants, it's important to note that the scientific objectives or goals of the study must be the primary basis for the inclusion or the exclusion of participants. We shouldn't include participants just because they are easily accessible, or it's easier to enroll them, or it's easier to get consent from those participants. Our main base should be the scientific goal, and also exclusion should also be reasonable. We have to be reasonable while we are excluding participants. We should have adequate scientific reason to even exclude participants. So the other thing is participants also should be selected in a way that it minimizes the risk and also maximizes the benefit to the individuals and also to the society. So we have to be fair in selecting study participants. Always the burdens of the research and the benefits should be distributed fairly during participant selection. We shouldn't we shouldn't ask some participants to bear the burden of the research to benefit other participants who are not taking the burden of the research. The other key ethical requirement is a favorable risk-benefit ratio. Whenever we are thinking of any clinical research, that research is ethically justified only if these conditions are met. The first one is potential risks to individual participants should be minimized, and the benefit should be maximized, and the potential benefit to individuals and society should be at least proportional or should outweigh the risk. So this risk-benefit analysis is in line with the principle, the ethical principle of beneficence and non-maleficence. So ensuring that the benefits outweigh the risk is important to avoid exploitation of the study participants. The other important ethical requirement is independent review. Always when we think of doing any clinical research, we all know that it needs to pass through an independent review by the Research Ethics Committee or the Institutional Review Board. So as we all know, as investigators or researchers, we may have some competing interests which can lead to conflicts. So we may need to complete a study in some limited period of time. Because of that, we may modify the methods to accommodate the time constraint or something like that. Or we may exclude some participants which would take more time to enroll or to get consent or something like that. So because of such different scenarios, it's likely that researchers or investigators will have a conflict of interest. Because of that, it's important to make any study or clinical study to be reviewed by independent reviewers who are not affiliated with the research. So normally we have to have IRB approval before we do any clinical research. So this is one of the requirements. So the other important ethical requirement is the informed consent. So the informed consent has two main objectives. One, it will help us to ensure that individuals will have a control over whether to be enrolled or not enrolled in a particular research, and also it ensures that participants will participate only if the research is in line with their interest, values, or preferences. So in order to assure that, we need to get a valid informed consent, and always we have to make sure that the consent is informed. The participants should be well informed about the research, about the risks, about the benefits, and all important aspects of the research, which would help them to decide whether to participate or not to participate. The other issue is respect for study participants. Of course, one of the way we show respect for participants is through informed consent, but that's not the only thing we have to do to show our respect. So respect to participants should be given from the time they are approached to participate in the study, throughout their participation, and also after completion of the research. So this respect includes, like, we have to protect the participants' confidentiality and privacy, and also we have to provide opportunity to withdraw at any time during the study without penalty. The other is, whenever we get any new information regarding the study, we have to provide that information to our participants, and sometimes we may have to also get another consent or reconsenting if it's necessary. The other is, we have to monitor the well-being of the participants throughout their participation in our clinical research, and also, even though it's not usually done, it's important to inform the participants the results of the study. It's also, in a way, recognizing their contribution to the research, and especially if it affects their health, it's important. Even the ethics committee strongly recommends researchers to communicate study results. The other is, we have to also compensate participants for any research injury which might arise during their participation. So these are the important ethical principles any investigator or researcher should adhere to while thinking of any clinical research. Now let's look at the responsibility of researchers. We'll have some slides on this, and also research misconduct briefly. So responsibility of researchers include proposal development, obtaining ethical approval, and this is important before starting any clinical research. And also we have to ensure protection of study participants. It's not only the responsibility of the ethics committees to ensure protection of study participants. As investigators or researchers, we are also responsible. And also we have to strictly adhere to ethical principles from national and also international guidelines. We have to adhere to study protocol and essential professional standards. And we have to also be able to generate credible data. So research integrity is one of the important things we need to have as a clinical researcher. So research integrity starts from the study design. So we have to have research integrity during designing our study, including our statistical assumptions, sample size determination, randomization, and during conduct of the study, conduct and recording of the study, we have to use appropriate standards, we have to use appropriate recording formats in order to keep the research integrity. During analysis and reporting also, it's very important to be honest in reporting results. We have to report even negative results with honesty. We shouldn't omit important results. And also we have to keep scientific validity by using appropriate analytical tools. It's also important to disseminate our research findings in peer-reviewed journals. So this is important. It's important for us to keep in mind that research integrity starts from the design up to the final analysis and reporting. So coming to scientific misconduct, I think it's important for us to know scientific misconduct as researchers. So it's defined as fabrication, falsification, or plagiarism in proposing, performing, or reviewing or reporting research results. So fabrication is just making up data or results and then recording and reporting them. But falsification is manipulating of different parts of the study, including it could be the research materials, equipments, processes, or any part of the data. And plagiarism is use of another person's ideas, processes, or results without appropriate credit to that individual. So there are consequences to serious consequences to scientific misconduct. This could include injury to patients and to health delivery. Depending on the type of misconduct, it would waste the limited research resources we have. It could lead to also questioning or doubting of all past work of the guilty researcher. So if as a researcher is found to be involved in a scientific misconduct, then all the research works which he or she has done in the past would fall under serious questioning. So in summary, as a clinical researcher, we are responsible to not only to advance science, we are responsible to protect the research participants. So in order to protect research participants, one of the most important things thing is scientific validity. We have to use proper research methods and have proper analytic plan and so on. So scientific validity is very important. The other is we have to obtain appropriate or valid informed consent from each research participant. Risk-benefit analysis is very important, it's very critical. While thinking of any clinical research, it's important to analyze this so that we can maximize the benefit and minimize the anticipated risk. The other is fair selection of participants is very important. It's important to be fair while distributing a burden of research and also benefit of research. And the other is it's important to conduct research with integrity, starting from the design up to the analysis and also reporting of the results. And also we have to comply with the recommendation by the research ethics committees. So this is all I have. So if you have questions, you're welcome.
Much, Dr. Gebre. I think it's let's maybe carry on and hear Bruce's talk, Prof. Bicard's talk on clinical research ethics, and then take questions at the end of this first presentations.
Thanks, Ella. And thanks, Dr. Meseret. I think my talk fits very nicely after Dr. Meseret's talk. And really what I've done is I'm going to talk about our experiences with clinical research ethics, predominantly across Africa with some of the big collaborative projects we've done and some thoughts on some of the challenges and solutions. So these are the funding, you saw them yesterday as well. So in summary, this is what I hope to discuss. First, the context in which we are trying to do clinical research at scale in Africa. And then a bit about the ethics and regulatory approvals, both the structure and function of ethics committees we've worked with in Africa. A bit about study design and the concerns ethics review boards have and some of the challenges. I'm going to suggest a few solutions which I think can help us with clinical research ethics in Africa. And then at the end, I've got two questions which I want to pose right at the end for all of us to consider. So if we look at the context of the researchers and the research environment, the researchers essentially in the work we're doing as a group are clinicians who are enthusiastic, but essentially are unfunded. The second part is the research environment that the majority of them have is extremely limited to non-existent. So they're very limited research support. And I think we just need to keep coming back to this figure. This is the reality for the majority of people who are doing research in Africa. They are clinician providers with limited research support, and they're working in a very demanding situation just because there's so few clinicians where they are. Despite this, we know that the clinicians in Africa are very keen to do important collaborative research, and this is obviously a strength of our network. So now what I'm going to do is I'm going to show you really what the ethics and regulatory approvals look like in Africa, and this is data from ASOS2, which was an interventional trial, and it's the data at registration from the national leads and hospital leads for the trial. So from 39 different African countries and 333 hospital leaders who registered an interest in ASOS2. So this is what it looks like. On average, there are about 4 ethics review boards per country. The constitution of the ethics committee is about 8 members. They meet probably about once every 1 to 3 months. And the fee structure for investigator initiated and led, and I think this is important, all the work we do is not industry funded, it's all research by clinicians. And the fee structure for that is unclear. So the first thing I want to show you is, in general, almost 60% across the board there's a very poor understanding of the ethics review boards in Africa. And I don't know if this is either as clinicians, we're unaware of the ethics review boards, or if the structure and frequency of events is very is not regular or scheduled. So 60% do not know if they're independent people on the review board outside of the local institution. The frequency of the meetings is unknown in 2/3 of the cases, and whether fee is payable is also unknown in nearly 60%. And I think this is really important. So it's a very strong message here that we need to know more about the local ethics review boards. I think the second very important observation is that the review boards meet most commonly 1 to 3 monthly. I mean, if a review board is meeting every 3 months, to approve a big collaborative project can take a long time. And so this is certainly an area which also needs to be considered and addressed. The next thing is that at any site, there are a number of ethics and regulatory requirements that have to be achieved. And so if you look at these responses, about a quarter will need a national regulatory approval. About a half will then need a further regional regulatory approval. And then there will be another quarter who require local ethical approval, and over half will also require local regulatory approval. This is extremely demanding and a lot of replication of services. So I think, you know, if you want to look at the ethics process to get a big project running across Africa, it looks like something like this. So you do your primary ethics approval, where the protocol receives its first ethics approval. From that point, it then goes out to all the sites that are keen to participate and countries that are keen to participate. A quarter will require national approval, half will require a further regulatory approval, regional approval, another half will require a regulatory local approval, a quarter local ethics approval. And then there's still, unbelievably, another 10% which will require other approvals. This is extremely demanding, and I would suggest a lot of these processes are redundant and repetitive, and they are not good for ensuring safe, ethical clinical research in our environment. Also, another thing is, that the local knowledge of the ethics review process is limited. And as I said earlier, it might be because the process is not clear or the clinicians are unaware of the process. But either way, only about 40% of clinician researchers understand the ethics review board process at their local site, but they have a very good understanding of the regulatory requirements, with over 80% being very clear on what's required. And if you look at the timelines, the review boards meet every 1 to 3 months, which means you do a submission, it's reviewed, comes back with queries, and then it's going to be another 1 to 3 months before the queries are responded to, and then another 1 to 3 months with all the responses again from the ethics, and quickly this process takes a very long time. If you look at some of the challenges that we have had with the review boards. So the first is, if we look at the different study types, the observational studies, the concerns have always been about finger pointing and data privacy. So concern that a hospital where the outcomes might be very poor is identified. But you know, on principle, in the APORG network, we've always worked on the philosophy that we will always ensure that all sites and countries remain anonymous, because basically the signals we are looking for are generalizable, that we can address at a continental level. And so, you know, speaking to ethics boards about that, I think obviously is extremely important to them, and it's an understandable concern. But I would say it's not a real concern, because we ensure that that's not, our intention is never to expose sites to countries. In the interventional trials, so I think this has been extremely important learning in ASOS2. We had nearly 10% of the hospitals, we never achieved ethics approval, and hence they could not participate. The basic or most common concern was a lack of equipoise for the trial. Most of the ethics boards felt it was unethical not to provide the intervention of increased postoperative surveillance. We obviously had a lot of face-to-face meetings with these ethics boards, but we still could not achieve ethics approval at 10% of the hospitals. And I think this is extremely important discussion for a number of reasons. So for ethics, for research to be ethical, there has to be equipoise. In other words, we are not certain that intervention will provide improved outcomes. So in ASOS2, the equipoise lay in the fact that if we provide more attention to the sick patient, does that mean the low risk or not that sick patient will do worse? In other words, there's less time looking at that patient, and that's actually where the equipoise lies. And it's interesting at the end of ASOS2 now to know two things. Firstly, asking doing the clinical trial was important, because even though 10% of the ethics committees felt that it was unethical and we should just be doing it straight off, if we had done that, we wouldn't have known now that providing increased postoperative surveillance did not improve the outcomes for the patients. And in fact, we've learned where the ethics boards felt it would. What we've actually learned is that it's much more complicated, and there's a whole lot about implementation fidelity, which is extremely important if we want to improve outcomes. That's the first thing. And the second thing, we actually have learned from ASOS2 that providing care for the very sick patient didn't compromise the outcome of the low-risk patient. And that's a super important signal we've learned. And it means in the future, it is ethical to provide studies which are only looking at the high-risk patient, because we know the low-risk patient hasn't been compromised by that strategy. Another problem that we had or have had with ethics review boards is that when the primary ethics approval comes from another country, there's an assumption that lots of ethics boards make that the investigators are therefore well-funded. And there are these ridiculous ethics review board fees as a result. And as we all know, none of us are well-funded. And we've done a lot of this research with almost nothing. And certainly face-to-face meetings, again, with ethics board are super important for them to understand actually who we are, what we do, and what our vision is for improving care in Africa. How does one go about managing these mass ethics approvals? I showed you how much redundancy there is. In fact, how many times you dealing with ethics review boards just for one site. And if you consider if you got 300 sites, what it could be like. So the advice is firstly to have a frequently asked questions document. So a lot of very similar questions come up from review boards. So every time you get a new query from a review board and you prepare a response, keep that response as that question and response as a template, and you build up a very big document so that you can deal with the concerns that the ethics review boards have. I also would really advocate, meeting with review boards, having face-to-face meetings. This is a very productive way of understanding their concerns and ensuring they understand what you intend to do. And then we'll look at 2 questions, which I think could be part of the solution at the end. So I just want to go back to face-to-face meetings with ethics boards. I think this is the most important thing we can do as clinician researchers, is it helps us understand what they're worried about with the research. It's often hard to communicate that in an ethics review board response to the investigator. And it also helps us ensure they understand what we're trying to do. Often, I think a review board might not totally understand our intentions, and to be able to talk honestly is very helpful. And I think, as clinician researchers, we also got to realize that every time a decision is made, either ethical decision or a regulatory decision for research, it is potentially precedent setting, which means that will be how it will be at the next time we try and do a project. So this is it's incumbent upon us then to challenge ethics review boards where we believe the request is inappropriate. And so there are situations where the need to consent a patient in observational work might be inappropriate, and it might create bias in the study and the data collected. And we need to challenge that. We need to discuss it with the ethics board, and they need to understand that. And similarly, the exclusion of certain high-risk patients from studies certainly creates a lot of bias in the sample, and discussing that situation as well is extremely important. So you'll see, if you look at the work that APORG has done, we've had waivers of consent to allow us to keep data on patients who've died, for example, so that we don't have a biased sample which only looks at the healthy patients. We've had broadcasting as a form of informing the population that a trial is happening, for example, in ASOS2, where there's signs in the hospital saying this hospital is part of a project or a trial, and you have the option of opting out, as opposed to the converse where you have to consent every patient to opt in. So I think these are really important, and it's really, we have to ensure that we work ethically, but the ethical demands on the research are reasonable and do not compromise the data, because that's no service to society at all. If you look at, where we're going, I think our vision for perioperative research in Africa is to develop this holistic research culture, and I think we certainly are moving that way and getting there. If you look at APORG, we've got people who've registered from over 42 countries now, 705 hospitals, and nearly 1,500 clinicians across the continent. And really what we have to do is provide a research infrastructure support for this group to ensure that, we can all conduct research ethically, but also quickly. And so how do we do this? So if we go back to the APORG member database, so on that database, we want to have all the clinician investigators, which lists their research interests. And also we keep records of their GCP accreditations and provide information to let them know when they renew the data or need to renew their GCP. So for example, in ASOS2, getting the GCPs for the whole continent was like extremely difficult. It was a hell of a lot of work. But the reality is that has helped us now build like a big database of GCPs of clinician investigators across Africa. And now, as a service to the investigators, we can provide reminders of when their GCP is about to expire so that they can do it timelessly, and it would be a lot easier. Similarly, on the database are all the studies with the documents needed to do the studies and to do ethics approvals, who the collaborators are, and all approvals, and then facility data. So in the studies, to understand the context of the data, or we do need to understand information about the facilities that each of us work in. And so if we keep a live database of all our facilities, over time that we don't need the redundancy that every time we do a study, a hospital investigator needs to put that information in. It exists already. So I'm going to just show you quickly. So this is the African Perioperative Registry or network, which I encourage all of you to, if you haven't registered yet, to register on it. This is the QR code and what the sign-up page looks like. Once you're into the registry, if you look at that red oval, you can see there that there's the home page, then there's a page which shows all the studies, this is the page you can see, and you can see I'm on you can see the ASOS speeds study information down at the bottom. Then you can see there's a facilities page, which shows all the facility data that we have, so that you don't have to re-enter it every time we do a study. And if a certain study requires a new little bit of information, that gets added to the facility data set. So we've got an ongoing data set which is updated and appropriate, and it helps us understand the background for each study. And then there's a tab which has got all the members of the APORG group. If you clicked on the ASOS PEDS study, for example, a new page will come up, and this is the ASOS PEDS page. And here's one can find all the documents, for example, for the protocol, the case report forms, etc., that are needed for understanding the study, for doing ethics and regulatory approvals, who's participating, what hospitals have expressed interest to participate, and what universities. So all the information is there for the researchers. There are a lot of other freely available resources for ethics or ethical research, and I think in time I would like to see these also populated on the Perioptip Network database, links to all these resources, but I've put together a few which I think are really good. So there's a Global Health Network where most of the clinician researchers in Africa did their GCP training for ASOS2 through that. It's an internationally accepted GCP course, and it's free. It's very good. And then if you're trying to set up your own research projects, there's excellent protocol templates and research training in the EDCTP website. And again, it's all free. And then finally, ultimately, we do need to know where all the ethics review boards are in Africa, and who the contact people are. I think that is key if we want to do big research and continue to do that in Africa. There is a project known as the MARC project, which is trying to map the African review boards, ethics review boards in Africa. It's driven predominantly by the infectious diseases groups. It's not complete, but I think these are probably a project that we should all be looking at, is ensuring that we know all our ethics review boards and how to contact them and how to communicate with them. So, in summary, I think, we're doing research as under-resourced clinicians in an under-resourced environment. On the whole, I think the ethics structures in which we work are not well understood, and there are numerous regulatory and ethical requirements. And to be honest, I think a lot of them, there's redundancy as a result, and that needs to be addressed. I think there is extreme value in face-to-face meeting with ethics review boards or the ethics chair, and I would really encourage this, and I'm happy anytime to speak to an ethics review board. I think there are a number of solutions to empower clinical researchers in Africa. There are a lot of very good freely available resources, and I do think the African Perioptip Network database also provides tremendous support for clinician researchers. So this is my last slide. I got two things I think we really need to discuss honestly and often across the network. And the first is, would people support the development of a regional ethics review board? And for big collaborative projects where in a region, certain countries get together and say, yes, I'm happy if this ethics ethical board member is part of this regional board, and if the regional board approves a project which has representation from different countries, that approval will hold in the different countries. I think, if we want to improve outcomes in Africa, and we want to do it at scale, and we want to do it timelessly, we really need to streamline the process. So that the first thing is, I think we need to honestly look at regional ethics review boards. The second thing is, would countries or hospitals consider reciprocity from specific ethics review boards? So are there ethics review boards in Africa that people will consider that their process and practice is of such a high standard that if a project is reviewed and accepted by that review board, other sites will accept that review as acceptable and accept their ethical decision? Thank you.
Thank you, Bruce. I'd like to apologize to the organizers. I think we're running quite a bit over time with this first talk, but I think if we can aim then to spend another 5 minutes on the topic, and then decrease the break time. I hope that would be acceptable. So Bruce, just from my side, there's currently no questions in the chat, and I hope that people will post their questions there, so it would be easier to get the responses from you. I just have a couple of questions, and maybe I would like your view on this. So the first thing is the data that you showed obviously is from different sites. So it's not categorized per country. So, and I know it's unpublished. So if one shares that type of data with national leaders, and discuss the solutions or possible solutions on a national level for these queries, do you think that's going to make a difference? Also, if you categorize the data according to country origin, don't you think that there is possibly, empowerment just in improving research capacity by empowering national leads with this knowledge, so that they can then at a national level, try and find solutions for this, and also try and find answers to the two questions that you posed at the end. That's the first thing that I just want to ask you. And then I've got just, short other questions. Maybe I would like, it's interesting to, what we've seen is between different IRBs, the issue about waiving consent for an observational trial. I think that's also something that was a topic of conversation during ASOS. So I wonder if you can comment maybe on that. And yeah, I think, if also the differences between the regulatory requirements and the ethics requirements for local sites. That was, in South Africa, where I was the national lead, one of our biggest problems, because between the different regional institutions or provinces, it was difficult to understand what the actual requirements were for regulatory approval. And is there something that you can share with regards to regulatory or government approval in comparison with, or in contrast to the ethics approvals that gave you insight in these studies?
Thanks, Helen. So I think the first thing, your point about the national leaders is very important. And I suppose the first question I posed is about, can we get a regional ethical process going? But your point is well made. I mean, the first thing we actually should be trying to do is, can we get a national approval that the whole country would accept? As soon as you go out of a country into a region, it's a lot more complicated. But maybe the first step should be in countries, can we get a national approval which is accepted? And sharing the data with the national leaders probably would help a lot. The one thing I didn't discuss, but is certainly relevant to the countries, is just like the clinician researchers, which is all of us, you know, are working in a very difficult environment. Similarly, the ethics review boards have the same scenario. You know, they are exactly like us, they're just in a different role. They're under-resourced. Again, they probably fit into that category of less than one provider per 100,000. And now they got to do ethics reviews, and they don't have a lot of support. As we saw, you know, average review board is 4 people, and that's probably 4 people from a whole big region. So extremely difficult as well. So, you know, talking to review boards and meeting them, I think they really appreciate it because it's difficult for them as well. And maybe, yes, we should be in a more collaborative approach, working with national leaders and seeing if we can start to, you know, organize with the ethics review boards for a more maybe consistent way of doing reviewing at a national level to approve projects. Does that sort of answer your first question?
Yes, thanks. Sagomi Mashinwi also then commented here, and she says, isn't it risky to decentralize ethics reviews as you may lose the inputs from local researchers, especially as we aim to increase research capacity?
So I mean, it's a difficult question to answer. My feeling is, and what we saw from ASOS2, for example, where, you know, we could not achieve ethics approval from 10% of the sites. I think what certainly would have happened would be to strengthen the ethics review boards through bringing more ethics reviewers together. I find as a lot of the sites have very small review boards, and it's very tricky for them to manage some of these projects. I think sometimes they're quite difficult projects and are quite. I'm nervous to use the word ethically challenging. They're not ethically challenging because they're unethical. I think they're ethically challenging because there's so many things to consider, you know, consenting versus non-consenting, what's happening to the control group. So there are lots of issues, and I sometimes feel the ethics review boards do not have enough support. So if we're going to increase research capacity, and I agree that's what we have to do at all the sites, I actually think bringing more ethics experts together, in other words, as having them, you know, like at a national level, maybe 5 ethics experts will probably be good for the education and knowledge of the group, as opposed to keeping the small sites.
Thank you, Bruce. There's another question here. I just want a quick comment. I think the reciprocity process, or how the decision is made to accept reciprocity from a trusted organization, is maybe in something in itself would increase research capacity. You know, I don't think reciprocity should be granted in a blanket fashion and just, you know, I think every single study that reciprocity is requested from should still be reviewed. It's just that if there is an understanding already in place, you know, it will make it easier for the local ethics board to understand the study and to have context to discuss it with at the reciprocal site. Maybe that would both increase capacity and knowledge sharing and decrease the onerous task of the local board.
I think, sorry, I know we're very late on time, but I think this is extremely important discussion, particularly in light of what Salome said and what you've just said, Heda. And it was something that I hadn't really thought about, but you know, if there are ethics review boards which are considered standard setters on the continent, and there is this consideration that maybe some of them could be used for reciprocal approval, and we want to educate and increase capacity, maybe then what we should be looking at is the sites who are considering or reciprocity, if those review boards would accept a member onto the board as not a member who interacts, because that would obviously be very difficult to navigate, but as an observer.
Or an ex officio member, yes.
Yeah, and who's involved in that project, can watch the ethic review process at the reciprocal site and how they deal with all the issues. And maybe that way we can start to develop or increase capacity.
Just a last comment here in the chat box. To get ethical clearance for clinical trial experimental research is very challenging, even in most of African countries. No IRB board, and it makes the process very difficult. And what would be the solution for it in the future? Could the APORG try to develop ethical guidelines and get approval from all volunteered and registered countries' authorized body? I think it's important now that we give our other speakers a chance and try to come back to this issue if we have time at the end. Are you happy with that, Bruce? I apologize for everybody. It's my job to keep time. So I would just like to then introduce our next speaker. It's Bezaye, who is an anesthesia lecturer and researcher in Deborah Beran University in Ethiopia, and she studied at Jimma University, postgraduately at Addis Ababa University, and she works as a clinician in Deborah Beran Comprehensive Specialized Hospital. She's passionate about surgical and anesthesia research and training, and she will be speaking to us about perioperative capacity in East Africa. And I just want to apologize. Please don't feel that we need to cut down on the time spent on the next lectures. Thank you.
Okay, thank you. As I have been introduced, I'm Bezaye from Deborah Beran University, Ethiopia. So today I'm going to just speak about one research, which is on perioperative care capacity in East Africa, the results of Ethiopian National Cross-Sectional Study. So going straight forward to the outlines, there will be the introduction of the study and the objective, methods, results, and conclusions will be reviewed. So as an introduction, as most of us would know, perioperative care is not only the intraoperative events in the OR and the surgery, but it extends from the preoperative evaluation and optimization preparation of the patients and the intraoperative events, the anesthesia and surgical care, and the postoperative strategies to just optimize and rehabilitate our patients. So if this perioperative care extends this much, it wouldn't be considered as a role of a single specialty. So it involves so many specialties in it, like clinicians, which might be anesthetists, nurses, surgeons, obstetricians, and other scientists like researchers, and leaders and other stakeholders will also have to involve and to collaborate as a joint single force, so that to produce a very safe perioperative care. So in recent years, the provision of safe surgery has gained considerable focus, especially in these 2-3 decades. But despite this increased awareness and very good emphasis given to this perioperative care, there are confounded by it's confounded by a scarcity of perioperative data. But there are coming to the data, there are about estimated 5 billion people which lack access to surgical care whenever they need it, especially in low and middle income countries. And perioperative mortality is also high in low and middle income countries. And surgical patients in Africa are at a very greater increased risk, and anesthesia-related mortality in sub-Saharan African countries is also a higher concern than in high-income countries, which is outlined by African surgical outcome studies. So this study is about East African outcomes, especially Ethiopian outcome. East Africa is a region in which is involved in the sub-Saharan Africa, containing about 9 countries, most of which have made very significant progress towards sustainable development. In this East Africa, Ethiopia has the largest population. As Ethiopia has the second largest population in Africa, it has the largest population in East Africa, which this country also made an effort to improve healthcare capacity within this last 2 decades, within this about 25 years. From these efforts, we could see that there has been an increase in surgical facilities from about 108 in 2013 to 289 in 2019. And also in 2019, the number of surgeries per 100,000 people was recorded to be 465 in Ethiopia, which has increased by over 10-fold from that of 212, and greater than the rate of the neighboring country, Uganda, which is recorded in 2019, which is 144.5 surgeries per 100,000 population. And also the maternal days rate in Ethiopia was decreased by more than half since 2000, since the recent 2 decades. But despite this expansion of the surgical service, there is an ongoing and widespread resource deficits or limitations all over the facilities in this country. So coming to the objectives, the aim of this study is to provide an updated overview of preoperative facilities status in Ethiopia, which certainly facilitates the identification of a future focus area, which could help us to just have an overview where should we focus on this perioperative care. So as a methodology, this study is an online national cross-sectional study, and it was conducted from September to November 2020. And the survey tool was developed from the existing tools, incorporating the element of this existing 3 tools, which includes the Safe Surgery Hospital Assessment Tool, the World Federation of Society of Anesthesiologists Anesthesia Facility Assessment Tool and the Lancet Commission on Global Surgery Surgical Assessment Tool. These tools, if you have seen them, they are similar except the differences of their specialty. So after just combining these tools, we have a final tool which have a final quantitative survey including about 77 checkbox questions, avoiding an open-ended responses for just clarity and days of completion. So after the survey questions have driven this, we have grouped into teams, we had about 4 teams, the infrastructure team, human resource team, service delivery team, and the availability of medication, equipments, and guidelines team were grouped. Then after an ethical approval was obtained from the Birmingham University Review Board on July 21, 2020. And this online survey link was sent via email or telegram to a network for perioperative care collaborators at each site. All collaborators were perioperative practitioners, anesthetists, surgeons, obstetricians, nurses were our data collectors. And after the data was obtained, the survey data was analyzed descriptively using Microsoft Excel to give these results. So this is a distribution of surgical facilities and responding sites. So response were received from surgical facilities within all the 10 administrative regions and 2 chartered cities in Ethiopia. So our respondent sites was more or less representatives of all regions. So we had a total of 81 facilities from 289 hospitals which completed the survey. So as I was mentioning earlier, there was themes in our questionnaire. So the first one was an infrastructure theme, and so under this an infrastructure theme, we could see number of beds. For example, there are about 4,110 beds, a total of 4,110 beds, which most of these beds goes to the referral level hospitals, about 1,512 beds, which is about 61.1% of the total beds are found in referral level facilities, and about 254 or 10.3% of these beds are found in primary level hospitals. And OR tables, there are about 257 OR tables, which again, the maximum or the highest number of these OR tables goes to the referral level hospitals. About 152 of these beds are found in the referral level hospitals, where only 34 OR tables are found in primary level facilities. So anesthetic preoperative clinic are found in 30 of the facilities from the 81 responding facilities. PACU, there are about 68 facilities having the PACU, 39 facilities has an ICU, and all 81 responding institutions or facilities had an oxygen cylinder in OR. Functioning anesthesia machine in each OR, 74 of our respondents had a functioning anesthesia machine in OR. The rest 7 might have a functioning anesthesia machine in the facility, but they do not have a functioning anesthesia machine in each OR. Piped oxygen, none of our respondent facilities had piped oxygen. And a backup generator, about 7 does not have a backup generator standing up. And so going to the service delivery and workforce team, facilities reported performing a mean of 6.9 surgeries in a day, which ranges about 1 to 37 surgeries per day. And talking to the about the workforce, about 23 facilities had no specialty surgical force. About 25 of them had no specialist obstetric workforces, and only 30 facilities reported having subspecialist surgical force, which most of the 30 subspecialties are concentrated in the center of the country. In the majority of the facilities, about 63 or 77.8% of the facilities did not have a physician anesthesiologist. So most of the care in this country is given, most of the pre-operative care is given by non-physician anesthesia providers and the integrated emergency surgical officers, usually especially in primary and general level hospitals. And as we have seen before, there are about 68 facilities which reported about having a PACU. So from these 68 facilities having a PACU, about 21 had trained PACU nurses. And the 3 of them had not even delegated PACU nursing staff, which is responsible for the PACU. And seeing the nurse ratio to the patients in the PACU, about 22 of this PACU from the total 68 facilities having PACU have a nurse-patient ratio of 1:2. In the rest of the hospitals, one nurse would oversee all the patients in the PACU. And only 5 of these facilities having the PACU had an assigned anesthesia provider responsible for the PACU. And so coming to the equipment and drug availability, the availability of internationally recommended monitoring devices like pulse oximeter, echocardiogram, and non-invasive blood pressure monitorings were they were found in about 68 of the facilities, which is 83.9%, especially pulse oximeter was found in most of the responding hospitals. So for this, I guess we have to thank the oximetry providing projects, which was done in these 2 decades, the recent 2 past decades. And capnography is available in about 27 of the facilities from the 81 institutions. This capnography is a very vital, I guess, monitoring device, especially for perioperative care, as it could tell us much about the ventilation of the patient, but it usually is not available in our facilities. It kind of is considered as a luxury equipment. And a section was available in all of our, the responding institutions, but it usually is shared between the anesthesia and surgeons in about 37 facilities, and sometimes it even is shared between the OR and the PACU. And availability of airway equipments. So as you can see on the figure, the light gray is indicating the availability of pediatric airway equipment, and the dark gray bar is indicating the availability of the adult airway equipment. So as you could see, the chart or the graph, the availability of pediatric airway equipments is limited more than adult airway equipment availability. So as it's known, Africa in East Africa, of course, is a home of pediatric age grouped populations. So having a less amount of pediatric airway equipments would also contribute for a higher anesthesia-related pediatric mortality and morbidity of these pediatric patients. And coming to the each airway equipment, so the face mask and breathing circuits, the adult ones are found in all of the responding institutions, but the laryngeal mask airway, even the adult ones, most of our facilities lack this laryngeal mask airway, which is a very important instrument, especially for managing difficult airway and complicated or failed intubations. So this equipment is scarce in most of the facilities, the responding facilities. And availability of medications in operating rooms. And again, as we all could see on the table, the availability of ketamine and thiopentone from induction agents, succinylcholine and beclonium from muscle relaxants, halotine from volatile anesthetic agents, petidine from opioids, and adrenaline and atropine from emergency medications are much more good when we see from the numbers. But the availability of the recently specially recommended drugs like propofol from the induction agents, rocuronium from muscle relaxants, sevoflurane and isoflurane from volatile anesthetic agents, and the short-acting opioids like fentanyl and dalfentanyl, and ephedrine and phenylephrine from emergency medications. They are, as you can see, scarce. There is a very less availability in this drug. So this would make the anesthesia provider, especially, or the anesthesiologist, not to make patient condition center decisions concerning the drugs. So this will also contribute much on increased mortality and morbidity of perioperative perioperative patients. So, and availability of guidelines. The use of WHO surgical safety checklist was reported in about 70 facilities. About 86.4 of them have used WHO surgical safety checklists. Again, we have, I think, to thank the Ministry of Health for this, for just enforcing the use of WHO surgical safety checklist, especially within the last 10, 15 years. I guess, and an operating room logbook was kept in about 75 of the facilities, and perioperative morbidity and mortality reviews was done in 55 or in 67.9% of the responding facilities. And guidelines like patient transfer and handover guidelines, PICU care guidelines, postoperative nausea vomiting management guidelines, acute pain assessment, postoperative pain management, and PICU discharge criteria guidelines availability is very limited, as you can see on the numbers. So just to conclude, despite the expansion of surgical accesses, there is an ongoing and widespread resource deficits if not all, in most of our facilities, and the expansion of surgical capacity should be accompanied by similar expansion in the provision of adequately equipped and staffed post-anesthetic care units and focus on post-operative care. So especially when we are expanding the surgical capacity or the surgical access, we at least have to expand a very crucial resources, equipments for those facilities we are building. Unless we are having a good resource facilities, these facilities will end up to have to increase the mortality and morbidity rates of post-operative, perioperative care. And especially here in Ethiopia, the post-operative care is usually neglected. So we all should have a focus on post-operative care. And the Ministry of Health's coordination of improvement activities with local and international partners is very vital in achieving this. And so I would like to conclude by saying everyone deserves an affordable, timely, and safe perioperative care whenever it is needed. Thank you.
Thank you very much, Pizai. That was extremely interesting, and I have to congratulate you on this very important work that you've been doing. Especially, I personally think the response rate that you had is great, considering that your participants were all perioperative clinicians. I think locally here in South Africa, we sometimes find that the clinicians don't have the buy-in to participate in these type of surveys, and they rely on hospital administrators to provide the data. So it's really an immense work that you and the participants have done. Congratulations. I would just like to then, so lots of congratulating messages in the chat box. No questions at this stage, so I think we'll move on. I would like to then introduce Dr. Luigi Pisani. He is an Italian intensivist anesthesiologist working in ICU in Italy, but he's also a project coordinator for the Critical Care Africa Asia Network with the Mayadol Oxford Research Unit, or MORU, and he works on ICU registries and does registry-based research in more than 10 countries. He's done his PhD at Amsterdam on mechanical ventilation monitoring in low-resource settings, focused on mechanical ventilation observational studies in Asia and lung ultrasound applications in the critically ill patients in low and middle-income countries. He's also responsible for the critical care research for the NGO Doctors with Africa, or CUAMN. He will be speaking about Critical Care Africa, the results, challenges, and opportunities for linking and building critical care capacity in Africa. We look forward to your talk, Luigi. Thank you.
Thank you, Haile. Thank you very much for the kind introduction, and to Fitsum, Dr. Manbeu for the invitation. I speak on behalf of the network, and also Rashan, Anifa, Habibin, and all the team that is doing this fantastic work. We do, as disclosures, we do receive funding from UKRI for the African network work, and from the Wellcome Trust for the Asian work, and also for the extension I will mention. My plan for today is to give a little background on critical care in LMICs and ICU registries, a little bit on the network of ICUs that is evolving, data management issues, some practical examples on how, what is the value of ICU registries in our practical lives, challenges, and some conclusions. Little bit of background. You all know that ICU care is expanding very quickly in low and middle income countries. There are gaps, of course, in quality of care, in outcomes. We heard yesterday, and we know that the ACEs and the ACUS studies did shed a light on many disease and on COVID ARDS, of course, in Africa. But we still need a lot to do on data, on capacity, on case mix, on outcomes. There are so many geoeconomic variations. Things are not always as easy as they look. For example, recently we finished a geoeconomic analysis just out a few days ago on mechanical ventilation in non-ARDS patients across many, many countries around the world. And as you can see, the outcomes are very diverse across high-income countries, upper middle-income countries, and lower middle-income countries. But for example, we could not find any difference in the practice of ventilation. So these processes are complex and they need a lot of data and a lot of networking. And is there a role for ICU quality databases or ICU registries? There is several names to this. What are these registries? Let's define a little bit. They are repositories of routinely collected healthcare information. Their aim is very clear: to use data to improve safety and quality of patient care. They do provide indicators on structure, on how care is conducted, so processes and what is achieved. And they do rely on audit and feedback cycle, on which there is a lot of research done, and we know it's effective, and we also know that it's cost effective. Can registries help the first step towards improvement? Well, we think they can through providing data on service evaluation, outcomes, resources allocation, and especially what you have mentioned a lot during yesterday's talks and discussions, through the empowerment and enabling of context-specific clinical research. But also benchmarking at several levels and through the evaluation of the quality of care and then steps to improve it. This is a little bit the structure we use in our network. There is a core data, as you can see in the blue boxes, very simple data on admission assessment and discharge. And then based on your needs, you can add daily data, you can add COVID data, or you can add discharge or long-term outcomes data. It's really context specific. The network started in Asia many years ago. At the time was enthusiastically and unfunded work. It started in Sri Lanka, and the ICU registry then spread to 9 countries in Asia. 40 units in 2020, more than 150 now. It's really a learning by doing model. The principles are quite clear. We have several work packages on registry implementation, quality improvement initiatives, and clinical trials. Just a couple of words on how the data flows. So sites will participate data into national registries. For example, this is the Indian Registry of Intensive Care. There is centralized curation of this data to assure some quality processes. And then the data is fed back to the centers and to third parties. It's very important, and you all mentioned these in your talks, that we have clear principles of data management and data sharing. What are the principles in our network is, of course, international standards, a lot of work on this. The data ownership, that is always on the institution. And I think Professor Pierce mentions how important it is to keep ownership of data, but data creation at the centralized level. So there's a team in Sri Lanka working at data collection. With the housing force always stays in S2 when she's requested almost always now. There is a some data access committee that reviews requests for data, and the access committee has participants from all the countries participating in the registries. We use fair data sharing principles, and we use the credit publishing principles that are so important to control. Yes.
I'm sorry to interrupt you. There's a problem with the sound. I'm not sure whether it's your connection with your earphones.
Okay, I'm trying to update video for a second.
We can't hear much better now. We can hear a noise. We can hear that you're speaking. I think, I'm sorry, Luigi, carry on. Maybe it's just a few of us that are having the problem. Thank you.
I'll try and please do let me know if it's not clear.
No, it's still the same.
Let me try to switch network, maybe. Can you hear me now?
It's the same, Luigi. Is it not possibly your headset or your microphone? I think it's your microphone on your headset.
Okay, let's try maybe without that. Can you
Perfect.
hear me better now?
Perfect. Thank you.
Okay, thanks. Thanks for letting me know, and I apologize for that. And let me just continue. We did recently do a performance evaluation of the registry infrastructure. I mean, it's so important for you as investigators to know, is the data I'm collecting, is the infrastructure of quality? And we are happy to know that we are in line with many other registries worldwide. So it is possible to collect quality data in low and middle income countries. And we are very happy on that. And this data can then be used in several ways, for example, for observational studies like this one led by Dr. Bharath Kumar in India, analyzing more than 80,000 episodes and coming up validating a severity score specific for low and middle income countries ICUs. But also in the registry, we can enable large trials. You know these trials, you know the REMAP-CAP, the recovery study, and we are very happy that now more than 30 centers in the network in Asia are participating, more than 1,000 patients recruited, and several countries in Africa are now undergoing the ethical requirements to participate in REMAP-CAP, for example. And coming to Critical Care Africa, well, it is a sister network. It was born just a year ago, and we started with UKRI finding. It's really a south-to-south collaboration, learning from the Asian experience and focused on local stakeholders from several countries. There is Tim Baker in Tanzania, John Amwasi in Ghana, David Thompson in South Africa, and many others that are really building up national networks. In Ethiopia, we are very happy to collaborate with the perioperative network that organized this fantastic meeting. There is also 2 ICUs that started the registry in St. Paul and Abed, guided by Dr. Menbeu, and also 1 NICU in Waliso Hospital. And what are the principles? They are quite similar to the Asian network: local data ownership, a common data model to then be able to share and compare this data to other registries, not only inside our own network, but compare it with other networks around the world, also in high-income countries. We had 3 activities started last year in end of 2020, and it's registry implementation, it's identification of research priorities, of your research priorities in your sites, and those amenable of quality improvement initiatives, and of course, clinical trials. And interestingly, we are also going beyond ICUs. So, you know, in Africa, the severe patients, Tim said yesterday in his very nice presentation, the severe patient is everywhere. And so we do have obstetric, pediatric, and perioperative focuses. But the topic, the title of my talk was really how to link and build critical care in Africa. And I think here we do have some insight now on how to learn from the Asian experience and from the national registries coming up now in Africa. The message is really, there is now possibilities. We are privileged also to have funding, I must say, and this is a great privilege. So please do reach out if you are interested in joining with your ICU, the Ethiopian team of the Critical Care Africa Asia network. And Are we on the right track in terms of building a capacity? I must be sincere. I didn't know this paper from Catherine Chu that Catherine Chu showed yesterday during her talk, and I was like, are we on the right track according to this principle? And I'm happy I could tick almost all of these principles for a sustainable critical care capacity building. So we do have a focus on capacity building. We do have PhD tracks coming up. There are now 5 across Asia and Africa. Local co-PIs are in every country on all the studies and work that we do. It's really building a supportive environment. I think who used this word yesterday was Dr. Alengta, and I think we are really on this track as a network. This takes time. This takes time, and we heard that from Dr. Chu yesterday, but we are happy to spend this time if we are aligned with the principles showed here. And in what practical way we do this? Also through shared research questions. Just like in the APORG, you had a shared question that drove your trials. For example, just a few days ago, we had our first investigator meeting for a study looking at direct and indirect patient expenditure and out-of-pocket costs for patients that I think Dr. Munir said that it's a very important priority for the ministry, but also for many of you stakeholders. This was something mentioned many times. And please do come out if any of you want to be in the steering group of this study that we are just writing the protocol at the moment. And it will be a shared study across Asian, across African, and maybe also South American ICUs. Another example of how to work together is on a Delphi large study on ICU indicators specific for low and middle income countries. The work is driven by Brinda Pari from India, but there is also Ethiopian investigators and many others on a set of indicators that is fit for our ICUs in Africa and Asia, and this publication will soon come out. But going more practical, we have this, registries and networks are a toolkit, and how can we use this toolkit? Sometimes we don't use it, and we might just not use, the data we collect. But how can we use this toolkit in our daily lives? Of course, the perioperative network in Ethiopia has already shown very important work in national level. We have examples in Uganda, in Kenya, that I will mention. Studies running across countries, as I mentioned, but also very important at site level. A lot of my week is really passed through calls with sites at trying to disentangle what are the research priorities for sites. Is it severe malaria? Is it something else? And use the data to work on those research priorities. I think colleagues will discuss the Ethiopian very important experience on which we collaborate. But I would like to give a few more examples on how this network can help you in your daily work. For example, in Freetown, Sierra Leone, we have an obstetric focus in an obstetric high dependency unit. And we built on early work, looking at case mix in this HDU. And the treating team decided to focus on only one thing for a few months. So the patient accessing with sickle cell disease. So they implemented the registry. This is a dashboard that you can see from the registry, more than 500 patients recruited in 15 months. And what we found, for example, in this small group of patients with sickle cell disease is that they have very similar severity of illness at admission as compared to other patients, but they have much, much worse outcomes. And so QI initiatives are being born, for example, in the blood bank, on the transfusion pipeline, to try and improve this. And this is an example. Another example are embedded RCTs. In Uganda, for example, the ARISE trial led by Arthur Kwizera and coordinated by Daphne. So many sites, they are using the platform to enable this large African-based study on high-flow nasal oxygen in acute respiratory failure. And what can the network do for you, for example? Not only the digital platform, okay, we can use the platform and have the study forms and collect the data, but also project management support, data management support. And we are very happy to know that recruitment is really starting as we speak. A third example is, when something comes up to a national registry. It's very exciting when it comes up to a national group. So for example, in Kenya, the team has done a fantastic job in recruiting patients, more than 2,000 patients now under analysis. And we can now participate with some data to the evidence already raised by ACOS, for example. And for example, what we know now is that there is 1/5 of patients under mechanical ventilation in this mixed cohort of patients, not only COVID. We can say something on hemodynamic support, on outcomes, both in ICUs and HDUs, and of course in COVID versus non-COVID patients. And also here, this is the national dashboard. You can see we started very humble, and then sites will come up and the number of patients will increase. Then there is some plateau, and really you need daily work. We meet every week to try and push the work forward, and it's very exciting. And there is a rising interest. Dr. Wambui and colleagues just are collecting data now at the national level. And as you can see, Kenya has a very diverse, as most African countries, status of ICUs, and there is public, there is private, and private not-for-profit. And most people were interested in knowing more about registries or in joining their ICU registries. So this is very important data as well. And I would like to thank the national team in Kenya led by Professor Wangari Siika for really the great work that is being done. It's hard work, it needs time, we all know this, and we also learn from failures. But I think it's really important learning here. Another example is a subgroup analysis that might come. So you mentioned yesterday, Bruce, and others, that perioperative outcomes of children are important, but also ICU outcomes of children are important. And we realize in Kenya, there are so many children admitted to our ICUs. What are the outcomes? What are the resources they use? And are different methods needed? And Dr. Wambui is now analyzing this data. And final example, well, we need to get out of ICUs in Africa, of course. The severe children, the severe patient is also in the wards. If you have a pediatric ward with 10-15% mortality, isn't that an ICU, we may say? And so we are trying to experiment the use of the registry in pediatric wards, for example. And we are collaborating with one of the most ancient NGOs present in Africa. So Doctors with Africa, that's an Italian-born, but for example, it's present in Ethiopia, it's from 1980. So a large experience there in district hospitals and a low profile, hard work. And we will try and disentangle the severe patient. And Wolisio in Ethiopia, for example, is participating into this work. So really, there are many opportunities to join, not only through ICUs. And so if you know people that are interested in this kind of work, please do reach out. And last minute on challenges. Well, I'm really always afraid when I see these big lists of challenges. We all know them. Implementation is hard at different level, but overarching message is practicalities can be solved. And every day we are learning how to solve better. And as Bruce mentioned, ethical practicalities or implementation practicalities, we as a network, we can really help there. And registry implementation is really just the first step. And then we need an intention to use the data to drive things forward. And as someone said to me once, well, a network without the work is just an empty net. So it's really then daily work to use this data. We recently did an analysis also led by Vrinda on facilitators and buyers, and it's interesting then to see what these are in detail. And you can see that electronic data collection and participation in networks are considered facilitators, but we also have buyers like fear for publicity, fear for benchmarking that we do have to face, to discuss, and to solve. And concluding, registries and platform and networks, they are a tool. They are just a tool that then they're open for use in our ICUs, and let's use them. The community of practice that is born is the real driver, is the real gold. And please do reach out if you want to start the registry work in your ICU. You can take different angles. There is no parachuted work. Please reach out to me or to Dr. Sultan or to Fitsum, and we are really open to new centers, and there is also funding to help this. And I really want to acknowledge the team in the Critical Care Africa site leads and national leads to push forward this work. Thank you very much.
Thank you, Luigi. That is incredible work done by the group. I just have a quick question. We are going to break for 10 minutes, so we'll start the next session 5 minutes late according to my calculations. There are no questions in the chat box at this stage. I just want to ask you, in general, percentage-wise, what do you think data capturing, how much is done by clinicians, perioperative healthcare workers or critical care healthcare workers, and how much is done by administrative personnel across the network now?
Thank you, Haila. Yeah, that's a very important question. It is diverse. So in Asia, in many countries, it's residents and clinicians collecting the data. In Africa at the moment is funded data collectors collecting the data, and the data collector can have different background. It can be nurses, it can be also non-medical staff. But at the moment, we do realize that the medical staff in the ICU, they do not have time to collect the data, actually. But this is under discussion, of course, and different countries and sites do take different approaches.
Thank you. Any other questions? Thank you very much. I think we should go to break now. So I hope it's acceptable. Let's make it 13 minutes and we come back to the next session at 10 past 11 East African time. Thank you very much, everybody. Great session, very enjoyable. Thank you.
Good morning, everyone. We'll just make a start again. So welcome to the final session of the conference. I'm delighted to see everyone here and I hope you're all enjoying this so far. And I'd first like to thank the organisers for inviting me to chair this session. My name is Dr. Jolene Moore. I'm an anaesthesiologist based in Aberdeen in the UK. I'm a member of the World Federation of Societies of Anaesthesiologists Education Committee, and I'm programme lead for the Safer Anaesthesia from Education programme. I'm a member of the N4PCc network, and I'm very privileged to be involved in their work and some of the studies that you've heard about in this conference. In this final session, we have 3 excellent speakers lined up. And as before, I'd encourage you to please do add your questions to the chat. So to begin, our first speaker is Dr. Senait Kabedi. Having graduated from Addis Ababa University, trained in paediatrics and completed an MPH at Johns Hopkins, she is Adjunct Associate Professor of Global Health at Emory, Guest Lecturer at George State and Visiting Professor at Ethiopia's St. Paul's Hospital Millennium College. Dr. Senait has over 25 years' experience within the fields of maternal and child health and infectious diseases, working with many well-known organisations, including WHO, UNICEF, CDC, USAID, and many others. Today, she'll be talking to us about the need for improving awareness and research on antimicrobial resistance in Africa's acute care settings. I'll hand over to you, Senait.
Good morning. Can I share my screen?
Yes, you should be able to.
Good morning, everyone. My task today is to present on improving the awareness and research on antimicrobial resistance. I will be doing so by going through a few outlines as seen in the slide, starting with the AMR as a global health challenge, development of AMR, and the responses from the global and regional entities, and then end my presentation by highlighting some of the challenges and key messages. Antimicrobial resistance has become one of the leading causes of death based on the recent presentation that came out just 2-3 days ago from Lancet. That reported a finding from over 200 countries globally. There was 1.2 million deaths per year due to AMR or directly related to AMR in 2019. And the other finding is that most of these deaths are in the lower and in middle income countries like Asia and Sub-Saharan Africa. In Sub-Saharan Africa alone, over 250 deaths were reported in the same year. Another summary from this finding is that the organisms that are resistant are also the commonly occurring organisms that we usually deal in our clinical practices like E. coli, S. aureus, and the others. Methicillin-resistant Staph aureus alone was responsible for over 100,000 deaths. Not to forget that other pathogens like multi-drug resistant tuberculosis and third-generation cephalosporin-resistant E. coli are also gaining prominence in terms of being resistant. Antimicrobial resistant organisms, be it bacteria, virus, fungi, or parasite, are evolving and no longer respond to antimicrobial agents. That's when we say they are resistant. It is a natural phenomena, but however, this resistance is also accelerated by various risk factors. These risk factors or contributing factors namely include antibiotic misuse or overuse, be it in animals or humans. In addition, the lack or inadequacy of infection control practices, the limitation of diagnostic capabilities, the lack of surveillance and policy and regulations that may not be implemented are also another source that can contribute to antimicrobial resistance. Use of counterfeit antibiotics, which is very common in many developing countries, is also another important factor. And then also environmental contamination with pharmaceutical products are also another contributing factor for AMR. Antimicrobial use is not limited to humans, but as we know, it is used in many industries, and the contamination or the use of antibiotics in every product, such as even household chemicals, is also another issue that is contributing. We can see that it's also used in farming. They do contaminate our fruits and vegetables. In aquaculture, especially with artificial lakes and production of seafood for consumption are also another sources, and also the environment. This picture shows the interconnectedness of the resistance transmission between human, animals, the environment, and the health facilities. When we talk about antimicrobial resistance, it is in the health facilities that is very common, though we do get antimicrobial resistance in the community through various routes like consumption of antibiotic-fed animals that are produced for meat production and others. So this tells us that the connection or the intersection between the environment, the animal, and the human health is a very important aspect that is relevant when we are talking about AMR. And also the solution is also based on the One Health approach. So it becomes very critical that we are coordinating, collaborating, and communicating across these sectors if we are to curb the antimicrobial resistance, which is really picking up the pace. By far, the commonest associated factor is the use of antimicrobial. This is a study that is done in 20 industrialized countries that shows with each increasing use of antimicrobials, there is a linear increase in resistance in every country that was studied in the group. The same is true within the animal section. If you see the second graph on the right, in the animal section, the countries that are studied here, there was also a linear relationship between use of antimicrobials and resistance of organisms. We do have studies from Africa, especially the one in 2018 that examined the meta-analysis of 12 country studies, showed that antibiotic resistance in the animal industry was 86% and multi-drug resistant was 73%. And you can see the graph where these organisms were distributed. And this graph shows these factors, and then the low, high, and medium results from antibacterial resistance based on the different factors, the most important factors that are listed. Again, we see that the animal and the human consumption or misuse of antibiotics does feature out as being the most important contributing factor. We do have others like suboptimal diagnostics, suboptimal vaccination, and mass drug administration, and others also contributing as a factor. The development of AMR and clinical outcomes, I think the most important issue is that in the development of AMR, apart from the natural processes, mutation and selection pressures, gene transfer from other bacteria, particularly if we talk about the bacterial side, which may be generated by plasmids and other transduction and transformation processes, are very much relevant in terms of studying how the development of antimicrobial resistance occurs. This is one area of research which is which requires expansion and more effort to understand what genes can be identified for the different bacteria in order to target control of antimicrobial resistance. There are so many papers coming out. Some of the processes have a gene that can be shared by a number of bacteria, which makes it amenable to some of the efforts that are ongoing to produce a better antibiotic. The main 4 or 5 mechanisms are shown here. Once the antibiotic enters the bacteria, there are different mechanisms that render resistance and make the antibiotic ineffective for use, like the blocking of the penetration. You see a few examples of drugs that are listed there. Some of them play the role of resistance through target modification in the case of vancomycin and beta-lactams and others. The other one is enzymes, inactivation of these enzymes, particularly in aminoglycosides and macrolides. These features do play a role in making the showing us the mechanisms of resistance. Just to talk about a few examples of resistant microorganisms, vancomycin resistant enterococci is one of the serious organism that we see in hospital infections, particularly in post-operative cases. More than 95% of these infections are caused by the 2 species of enterococci. And this is one of the difficulties that we see in some hospitals. Carbamazepine resistant Enterobacteriaceae is another one. Again, this is a broad bacteria that has a family of over 70 bacteria. They are extremely resistant and associated with high mortality, especially in the bloodstream infection. The mortality can go as high as 50%. When we say carbamazepine resistant Enterobacteriaceae, the definition is that we're talking about those class of antibiotics, imipenem, meropenem, or doripenem. Clostridium is another common organism, which is a commensal of the intestine. And this bacteria has also been important in AMR. The risk is higher where there is a use of broad spectrum antibiotics or people who have serious underlying illnesses and the elderly. This bacteria has spores or forms a spore that can help it to remain in the hospital environment for longer periods. And these are some of the issues sometimes hospitals have to deal with, where you might see a closure of wards and decontamination before we are able to use the facilities again. Methicillin-resistant Staph aureus is a notorious condition, bacteria, where we see usually it might start as a skin infection, but can quickly spread and may go into bloodstream sepsis and may lead to mortality. Superbugs, also known as ESCAPE due to the acronym that is used for the 6 bacteria that are listed on the slide. They are usually resistant to multiple drugs and also cause serious infections, whether in post-operative or other kind of infections that we handle every day. So the issue has been gaining prominence, and also we are seeing how devastating the effect of AMR can be. There has been projections as to what can happen if the situation goes unchecked. In this slide, you see that superbugs bigger risk than cancer. If you look at the bottom of the graph, we can see what is the mortality from different causes. But by 2050, AMR is going to be the leading cause of death, contributing to 10 million deaths. Right now, we are around 700,000 deaths per year. Another important observation is also, as already noted in my initial slide, the current studies that did show the problem being more concentrated or higher burden recognized in the African and Asian setup is also likely to go higher if it is unchecked, where we see about more than 4 million deaths by 2050, according to this prediction. Looking at what the global and regional responses have been, and we've been hearing from the presentations, some of the studies and the wonderful work that has been done by some of our colleagues in the region, I'll just highlight the Global Action Plan, which provided a framework for action with some strategic objective, 5 strategic objectives, mainly to improve awareness of AMR. The awareness should go beyond the sectors, whether it is human health, animal health, or environment. It should also involve the public. The second strategy is strengthening the knowledge and evidence base through research and development, reducing infection through infection control mechanisms and processes, limiting the emergence of spread of AMR, and developing new tools to fight AMR. And of course, the surveillance system has been the one which has been gaining more traction and work that has been documented. There has been different standards and guidelines that have been developed, and these also transcend between the 3 sectors: the environment, the animal health, and the human health. Global Antimicrobial Resistance Surveillance System, or GLASS, is a platform for global data sharing. It supports global surveillance and research, and countries should be encouraged and are encouraged to join some of the multi-center studies and platforms to enhance this reporting and using the standardized approach to the collection, analysis, and sharing of data at global level. WHO also has a list of priority antibiotic-resistant bacteria that are monitored. This has 3 tiers: critical, high, and medium priority, and different antibiotics are listed in these groups. And this list or the tier might change for the bacteria based on the research findings. But at least what we can see is having this data is helpful in terms of gauging where our health facilities are, where we are moving towards in terms of determining the resistance pattern, and compare it to the global database in terms of measuring where we're going from the baselines. The strategic research agendas are mainly in the 6 areas. These are therapeutics, diagnostics, surveillance, transmission, environment, and interventions. So again, this kind of gives us a framework where to study which kinds of strategic agenda we would like to focus on based on the gaps that needed to be filled. One of the most important gaps is also the diagnostics that we see, particularly in our region. Mapping of antimicrobial resistance and antimicrobial use partnership project is a consortium of African Society of Laboratory Medicine and others. This project aims to collect from existing data baseline information to map antimicrobial use and also bridge the gap in data through digitalization and identifying areas of improvement for the countries to collect quality data. Policies and strategies, there have been very important policy directions that came out from studies and observation of the direction of AMR. Monitoring the antimicrobial use has been very useful, especially in the formulation of the policy to ban use of antimicrobials for animals for growth promotion. As you know, there are the animal production industry for food is using antibiotics just for growth promotion or getting higher yield in their product. And animals are provided with antibiotics even when they are not sick. So this process has been very critical, and Europe has succeeded in banning the use of antimicrobials in animals for food. And I think that's a great step towards the right direction. Whereas in the US, we have not yet seen this ban, and other countries are also need to see if they can pick up the effort on that regard. It's important to engage the environmental sector as well. Delaying emergence of antimicrobial resistant organisms through antimicrobial stewardship is another important aspect. This is usually done at the hospital level, but needs a policy support and commitment at the highest level to make sure that the organized governance and committees and the resources are available for antimicrobial use and also quality improvement, as well as discussion to show the data sharing across different hospitals to come up with a better plan and decision in moving forward. Limiting the transmission of AMR through infection prevention control, water sanitation and improving hygiene, as well as provision of personal protective equipment is also very critical. These are some of the shortages and the challenges, particularly in our African setting, where we don't have adequate water and sanitation even in hospital facilities, making it difficult to control infection. Strengthening biosecurity programs on farms is also part of the limiting AMR transmission strategies. Mitigating harm among AMR infected patients. This is also an important strategy. This calls for increasing development of new drugs and quality diagnostics to make sure that we are able to handle those cases that are resistant. The main competencies for AMR, especially for those working in the clinical setup and really working in the public health setup to ensure the control efforts is enhanced, are three. The foundations to build awareness, the appropriate use of antimicrobial agents, and infection control practices. The challenges are many, but I'll just highlight a few and then probably focus more on the African continent and talk about the drug discoveries in the next slide. In our setup, high level of AMR is already witnessed and we know about it. more than 1/3 of the countries have no recent AMR data published in the public domain. So the data gap is concerning because without data, influencing policy becomes difficult and implementing corrective measures and strategies that are useful to curb antimicrobial resistance becomes difficult. Another gap is also standardization and quality microbiological identification and susceptibility testing is also lagging. Studies in food animals also suggest that there is a serious threat for food safety and security. This is also a very critical gap, as well as the gap that we see in regulations, counterfeit drugs, being able to purchase antibiotics in formal settings, and also contamination of our waters and supplies because of lack of regulation on industries, where we have some pharma's waste being spilled into drinking water or the water system of the public. These are some of the issues that we can highlight as the challenge for antimicrobial resistance control. Another important global challenge is that if we go back in history, when the penicillin was developed in the 1940s, immediately after that, like between the decade after that, between 1950 to 1960, the discovery of antibiotics were much faster. There were newer drugs and more potent drugs coming to the market rather frequently than what we see after 1960, where we call it a gap or an innovation gap. So there is not a lot of new drugs that will help us move towards more potent drugs to deal with the resistance that we are having. That is a concern and a challenge for us, an area of research, but also an area of concern to ensure that we should try and also make our efforts much more concentrated on keeping the antibiotics that we are using working. That means limiting the resistance pace and making sure that we are using our antibiotics sparingly. Just before I finish, I would like to share the warning that was given by Sir Alexander Fleming, who was the person who discovered penicillin. As we said, resistance occurs naturally, and it was not long after penicillin was discovered that resistance pattern began to emerge. And the warning we had from him was that the time may come when penicillin can be bought by anyone in the shops. Then there is a danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug makes them resistant. So we did have this warning a long time ago at the beginning of the discovery of antimicrobials, which have changed the picture of infectious diseases, and which was a great milestone in the treatment of infectious diseases. But despite these warnings, we are still having antimicrobial resistance in our setup. So the key messages are that misuse of antibiotics is the main driver of AMR, and we need to counteract this. AMR threatens the effective prevention and treatment of infectious diseases. If we are going the same direction, common infections and minor injuries can become difficult to treat, and we will see higher morbidity and mortality from these causes. Successful surgery becomes difficult, and also cancer chemotherapy and other interventions like transplant may also be compromised. In addition, the cost of healthcare is going to be high because we will have increased number of days for people to stay in the hospital, as well as treating resistant organism by the second or the third generation of antibiotics will be more expensive. The general precautionary measures that we should aim at also includes enhancing infection prevention control, especially improving our water and sewage systems and managements, and reduce animal use of antibiotics and use of household and personal products that are containing antimicrobials. Policy becomes of paramount importance, especially in the area of optimizing surveillance diagnostics, and the same approach of antimicrobial use. The danger is that in the absence of new drugs in the pipeline, there is a real danger that we may be going back to pre-antibiotic era. And this is a critical issue. But I would like to finish with a positive note that resistance genes are available, or resistance is a reality, but their spread can be delayed. And I think that's where awareness and research is very critical in antimicrobial resistance control. Thank you.
Thank you, Dr. Senlight, for highlighting this very important and often underestimated issue. And it's really great to see all the work that you're doing to address this. At the moment, I don't see any questions in the chat, so please do add your questions there for Senlight, or you can add your name and we'll call upon you. I'll just ask you one question from myself, if that's okay. You've highlighted about the very high rates of AMR demonstrated in Africa, and also that AMR is a leading cause of death. Before the break, we heard about the use of ICU registries, and I wonder if you see a role for incorporating data collection on antibiotic use within registries like this? And if so, how do you feel it would contribute to tackling AMR or feed into the global surveillance systems and data sharing platforms that you've talked about?
I think that's a very good question. And it's very important, and because the health facility, one, is the main area where we are having antimicrobial resistance, whether the spread or the difficulty to see, and the mortality and the morbidity that we see really gives it a picture of what can happen with antimicrobial resistance. And ICU and acute care settings are also very critical. And it is possible to incorporate this data, even though there is not such a platform that is really laid out, but it is a very interesting idea to start with, and to try and see how this can be incorporated into the picture, where we can kind of see hand in hand what the surveillance shows and what the acute care settings and ICUs contribute, and how many of these resistant organisms end up in ICUs, and what the contribution is. And I think ICU is a perfect place to monitor for AMR. It becomes very critical.
Thank you very much. I don't see any more questions, so we'll move on to our next topic. We'll be talking about indications and challenges for implementing perioperative registries and the characteristics associated with successful registries in low resource settings. And for this, we have two speakers. First, we'll be hearing from Mr. Fitsum Kifley, who is a Global Surgery Fellow at University of Cape Town, South Africa. Fitsum has collaborated on research projects with N4PCc and APORG, and he's working towards improving the perioperative surveillance system for quality improvement and research collaborations. He will be joined later by Professor Bruce Picard, who I believe by now needs no further introduction, having contributed substantially to this conference so far, and whom you've heard from this morning. I'll hand over now. Thank you.
Thank you very much, Jolene. Greetings all. This is Basom, and I will speak to you about a recent systematic review. So our study aimed to understand the indications and challenges for implementing perioperative registry and characteristics associated with successful registries in low resource settings. So we will go over these presentation outlines in detail. So perioperative registries are databases that store information on surgery, obstetrics, and anesthesia. And later on, this information can be utilized for various purposes, like evaluating patient outcomes and developing AI, artificial intelligence predictions, mortality, morbidity predictions, and supporting policymakers and health professionals in making evidence-based decisions and interventions. So the problem is in low middle income countries or on low resource settings, they are in high demand. So our objective, our review objective, aims to assess the indication, challenges, and characteristics of successful perioperative registries in these low resource settings. So, the result from this study is expected to benefit to better understand and support ongoing initiatives to establish perioperative and other clinical registries in Africa and other low middle income countries. So our method was we conducted a librarian-assisted literature search on international research databases, which includes PubMed, Cochrane, Web of Science, and Scopus. This search was conducted from 22nd of June to August 10, 2021, and our search was limited to English studies, and we used mixed method appraisal tool for screening. So in terms of our inclusion criteria, we used PICO, PICO model, so population intervention and outcomes, and hence that made all of the following criteria were included. In terms of setting, countries with large perioperative registry or network, and hospitals in low or middle income countries. And the outcome of interest was implementation of perioperative registry in low resource settings, and the outcomes were indication, challenges, and characteristics associated with successful registries in low or middle income countries. So we tried to include quantitative, qualitative, and or mixed method studies. Then we excluded studies that were not part of primary research, such as articles reported to conference, commentaries, editorials, systematic review, meta-analysis, and other secondary studies were excluded, and studies that were not in English were also excluded, and when we were not able to find the full text, we excluded these type of studies. And on the MMT tool, or mixed method appraisal tool, there are two screening questions, and if the answer was no for either or both questions, so we excluded that study. So the questions were, the screening questions were, do the collected data information allow to address the research questions? And the next one is, are there clear research questions on the study? So if no for any of these questions, for any of these questions, then the literature will be screened. But if the answer were can't tell for both of the questions, then the research, the article will go for full full text review. And in order to avoid inclusion bias, the studies were screened by 2 researchers, and so where there were disagreements, the 3rd researcher resolved them. So when we see our results, a total of 2,793 literature were screened, and 900 duplicate records were removed, and 1,840 records were excluded based on the responses to the screening questions of the appraisal tool. And that is no for either or both questions. Those studies who were can't tell for both screening questions against the titles and abstracts were further screened for full review, and here 9 were excluded, as 4 were no for both questions and 5 were no for the first the mixed meta appraisal tool. The 13 full articles with 2 yes answers for the MMT screening were reviewed, and 3 were excluded since only the English abstracts were available. The full articles were not in English. So finally, then we included 10 eligible studies. When we see the indications for preoperative registries in LMICs, in this review of 10 articles, the biggest reason for implementing preoperative registries was to know patient's outcome. This message is quite important since it clearly outlined the challenges of knowing surgical patients' outcomes in developing countries. So investigators will be forced to try to build these registries from the scratch, and again from that study, again they will from that intervention, then again they will try to evaluate patients' outcomes. One thing that should be mentioned here, so in this review, most of the registries arose from investigators with specific outcome interests, which remains helpful in determining and minimizing the data sets. So this is quite important. The other reasons for implementing preoperative registries is conducting quality improvement initiatives and research, and also identifying risk factors, and also informing policy and practice. Then in one place, the identifying in a couple of places, identifying short-term and long-term training needs for medical and other health professionals is also mentioned. So when we see the challenges, so the main challenge was incomplete data, and of course there are the other mentioned reasons here can contribute for this. For example, the lack of finances, the level of training for data collectors, and the lack of technical team on the ground can play a role for data incompleteness. The other challenge is trust issue on data collection and software and storage. So in 3 of the articles, this was mentioned. And the other is high costs for software support from outside the country due to lack of an established technical team within the host country. So if there is a well-established system or technical team on the ground, especially within the hosting country, so it will be quite easy. So because the remaining task will be coordinating this team and trying to do the work. So, but in the absence of well-established team on the ground, this is quite difficult. Then lack of policy for data management and sharing. Yeah, even though this is mentioned or cited in 3 studies, it plays significant role in making the process more difficult in low middle income countries, since it causes investigators to knock numerous doors seeking support for collaboration, and this takes several time and also depend on the collaborators' personal interest and willingness. The other is insufficient funds to organize team, recruit data collectors. Is also mentioned. So when we see the characteristics, so engaging different stakeholders is quite important because there is no clear guidelines for data management and sharing. So engaging different stakeholders, obtaining appropriate ethical approvals, building local research capacity, and also providing adequate training for data collectors before commencing data collection. Then appropriate recruitment of data collectors in terms of skill mix and academic background ability are associated with successful registries. When we see the software or mobile applications, the design software and programs needs to be offline compatible and need to require a low bandwidth. This will help to avoid local constraints such as unreliable connectivity and also insufficient power supplies. And so again, the software needs to be easily adaptable and also locally made. So regarding the platforms or the storage, it should be very transparent, and it should use secure platform and needs to allow decentralization and fair principles of data management, i.e. findable, accessible, interoperable, and reusable. Then in one place, automated analysis and public view of core surgical indicators were also associated with successful registries. So in conclusion, the goal of proprietary registry is to generate data to influence and support national surgical policies and improve patients' outcomes. To address the enormous need for surgical treatments improve the quality of care care offered, and prevent falling behind in the field of continuous data-related technological advancements. Every effort should be made to build these minimal dataset registries, particularly in sub-Saharan Africa. So, having reviewed all this and understanding the pressing need for pre-operative registries in Africa, APORG network is seeking to establish a Pan-African pre-operative registry network that encompasses all the characteristics associated with successful registries in low-resource settings. So we hope your hospital or country or institution will contribute and collaborate to this plan and make it a success. Great, thank you very much.
Thank you, Fitsum. I believe we're going to go straight over to Professor Bruce Picard.
Thank you, Jardine, and thank you, Fitsum. So I think Fitsum has laid the ground for what one needs to do to have successful perioperative registries or registries in low resource environments. And I'm just going, this is an extremely short talk on the African perioperative registry and participation in it. So the registry will be supported by the African Perioperative Network and by Safe Surgery South Africa. And as I've said before, some of the funding for the Perioperative Network has been kindly provided by EPOM. So these are things I just want to touch on quickly. Why a registry? What would the registry be? How would we do it? And what are the benefits? So why an African perioperative registry? We know that perioperative outcomes and resources are limited in our environment. If we have locally owned data, we can use it for advocacy in our own environment. And we can also use it to track quality improvement initiatives. And at a continental level, if we have similar data, we can use it for leverage and advocacy internationally. So our first registry we propose is for perioperative mortality rate. We've conducted the Delphi and we've established the limited variables which would be required for minimum data set in Africa. And this would allow us to provide risk-adjusted mortality figures for institutions, and it would allow us to track our performance at our local sites. It's really important, perioperative mortality rate, as it is one of the Lancet Commission's for Global Surgeries indicators. From the minimum data set, one would need a limited number of variables in order to be able to do this and to risk adjust for mortality. And so essentially, these are the variables for the perioperative mortality rate data set. They're 10 variables, and it would be risk adjusted using ASOS surgical risk calculator. And we know from ASOS 2, where we use the risk calculator, that it performed very well in identifying our high-risk patient. So we're in the stage of the pilot phase participation, which is establishing a core set of hospitals, countries who want to participate. We're looking at sites to contribute either to define a set of surgical procedures or surgical disciplines, and then the sites to have local co-development in participation in the registry, and you can register your interest for participation on the African Perioperative Network database, and that's a QR code. The benefits of participating, well, you would have your own locally owned data, and it would also be risk adjusted. You can track your quality improvement initiatives at your own site, and you can use it for advocacy at your own site as well. So if you want to be participate, please register your interest over here. So in summary, why do we need a registry? Well, the outcomes in Africa and the resources we have are limited, and outcomes are poor. We know that perioperative mortality rate is one of the Lancet Commission indicators, and we should all strive to provide that data. You can participate at this point in the pilot phase participation or setting up the data registry. And the benefits is that it gives you locally owned risk-adjusted data, which you can use for your own quality improvement projects. Thank you.
Thank you both for that excellent overview of the current situation regarding perioperative registries in Africa. And it's very exciting to hear about the plans for the APORG-N registry. I'm not sure if Fitsum is back with us. He was having some connection issues, I think, but he's trying his best to get back online. I don't see any questions in the chat at the moment. So as before, if you've anything to ask, please do drop it in there or drop your name in there. One thing that I was going to ask about, and Bruce, I don't know if this would be the best question for yourself or for Fitsum. So if he's not back, we can always put it in the chat for him. He talked quite a bit about data storage issues and concerns and the importance of addressing that. And I wonder if you'd had some thoughts about how you might try to address some of those issues within development of the APORG-N registry.
So the experts in this space are Fitsum and Hela. I'm not sure if Hela's on the call.
I am here, Bruce.
You are. Hela, sorry to put you on the spot. I mean, would you be able to respond to Jolene's question?
Yeah, Jolene, I think you know, Luigi illustrated in his talk earlier on the critical care registry. He showed the architecture there of, you know, it's almost like a combined architecture and data governance model. And I think if you don't have a plan up front with regards to your data management plan and your data sharing plan, you know, then you're bound to run into trouble. And that's one thing that we're definitely focusing on is to have a pre-developed data governance and data sharing plan that that aligns with the FAIR principles, but has got very specific users and use case scenarios, both at a local or even a team level, as well as on a regional and national level, and then continental level. So, so we will be addressing those plans. You know, it depends very much on what is locally the culture, and you know, and I'm not talking just about a facility. I'm more talking about a national incentive. And personally, you know, I feel that the stakeholder and community engagement part of the projects is crucial to success. And while we accept that these initiatives must be clinician driven, it has to be supported by government. It has to be supported, and not necessarily financially. I don't think there's a lot of African countries that's able to support financially such initiatives by clinicians. But I think what is important is that conversations need to happen. Conversations with policymakers before, to make them buy into the concept at the same time that you're developing your sharing plan and everything else. Because that support just makes it so much easier to ensure that there is regulatory approval for the system, that there is ethics approval, but it also speaks to the sustainability of the model. So, stakeholder, and I think it's one of Fitzim's slides there, where he speaks about stakeholder engagement, which I think is scored there in his slide as the highest in the requirements for setting up such a registry. And I believe that, and I know that people that are already interested in participating in this pilot have got those engagements going, and that will influence obviously to a large degree what your data management plan is going to look like as well. I hope that answers your question, Jolene. I'm not exactly sure.
Thank you very much, Hyla, for stepping in. That was very helpful. I'm not sure if Fitzim is back with us. I think I'll just check if he's here. Fitzim, are you back with us? Not yet. So we'll just move on to our final speaker, who's Dr. Tajuddin Raji, who's Head of Public Health Institute and Research at CDC Africa. Specialised in paediatrics and public health, and with many years' experience in maternal and child health, humanitarian emergencies, health system strengthening and workforce development, Dr. Tajuddin will be speaking to us about this Africa CDC's experience and recommendations for the regional acute clinical care research community on building evidence, identifying gaps, and developing standard collaborative regional interventions. I'll hand over to you.
Thank you, Jolene, for that introduction. Let me try to share my screen. I have a couple of slides to take us through my presentation this morning. All right, can you see my screen?
Yes, we can, thank you.
Okay, all right. No, so once again, thank you, Jolene. So I bring you greetings from the African Union Commission. I also bring you greetings from John Nkegasong, the director of Africa CDC, who have actually loved to be here this morning, to actually do this presentation himself, but unfortunately he's far away in Washington. And let me also, use my Cape Town, affiliation to greet a colleague from UCT. So a couple of years back, I was at UWC for my public health postgraduate training. So having said that, I will attempt to take you through the Africa CDC's experience and recommendation for acute clinical care research community on building evidence, identifying gaps, and developing standards using the sort of a regional approach. And as you can see there, my name is Tajuddin Raji. I work for the Africa CDC. So, by way of introduction, the Africa CDC is a specialized technical agency of the African Union. And as we all know, the African Union is an intergovernmental organization. Africa CDC came into existence exactly 5 years ago when it was launched by our head of state government under the leadership of the then chairperson of African Union Commission, Madam Nkosazana Dlamini Zuma. And as part of our operating model of the Africa CDC, we have the headquarters at Addis Ababa within the African Union Commission. In each of the 5 African Union regions, we have what we call the regional collaborating centers. And at the level of each and every member state, we have what we call the National Public Health Institute, just like what you have in Ethiopia called the Ethiopia Public Health Institute, and what you have in South Africa called the National Institute for Communicable Diseases. It's also like the US CDC equivalent in Atlanta. Now, if you take a look at our strategic plan, looking at the strategic pillars, there are 5 main strategic pillars for the African CDC. We have some couple of cross-cutting enablers for those pillars. Now, of keynote there is that pillar that is looking at National Public Health Institute and research. So this is basically health system strengthening, research, and then some element of our workforce development. But much more importantly, if you look at all the other 4 pillars, you discover that research is a core component of that. If you look at surveillance, emergency preparedness and response, if you look at lab systems and networks, and of course, information system. And Julian, just to close up the previous session, you asked a question on data, and that pillar there, information system, is exactly what Africa CDC is trying to do at the continent level to bring all our member states to speed in terms of capacity and ability to share data and use data to inform policy and practice. Now, having said that, let me shift there and go to COVID-19 pandemic and the response and what have we done as Africa CDC. So just a week into the COVID-19 pandemic, we convey a high-level emergency ministerial meeting that brought together all the 55 member state ministers of health. And at that particular meeting, we did agree on the need to have a continental strategy to drive our response, the need to coordinate, collaborate, communicate, and cooperate as a way to effectively marshal a very good response as a continent using regional approach. And that regional approach, I think, underpins or is a critical aspect of what we are discussing here today. And let me also state here that if there's anything we've seen as far as this COVID-19 pandemic is concerned, is we have actually realized that clinical care, is much, much more closer to public health than what we usually think of. Because when you look at the COVID-19 pandemic, the proportion of patients who get admitted and those who go into the, the critical care unit, to optimize their care. So the COVID-19 pandemic has underscored a very strong tie between clinical care and public health. Now, as part of the continental strategy, we were mandated by the Ministers of Health to put in place different technical working groups. Now, for the sake of this discussion, part of this technical working included technical working group on case management. Coincidentally, that is also co-chaired by Africa CDC and South Africa. And another technical working group that is looking at research standard and regulation, that brought together most of the researchers on the continent on how do we, use evidence, that is coming in to guide our response to the COVID-19 pandemic as a continent. It's sort of locally contextualized evidence to guide our response on the continent of Africa. Another key lesson that we learn as far as the COVID-19 pandemic is concerned is the critical role of our National Public Health Institute, by extension, our local research institutions, our academia, and so on and so forth, because we believe that, what the COVID-19 actually told us or actually showed us is the fact that all these key institutions need to collaborate, need to coordinate to be able to mount an effective and efficient response to the pandemic on the continent. Again, we also learned that there is need to have a locally contextualized guideline to drive the response. And you will agree with me that You cannot talk of a locally contextualized guideline for a continent of 1.3 billion people, 55 member states, without looking at it from a regional point of view, without regional coordination and collaboration, which again underpin what you have been here today. And we have several guidelines on infection prevention and control, case management, critical care, and so on and so forth. And all these were work done through that regional collaborative approach, through the researchers, the lead experts, critical care, case managers, surveillance experts, and so on and so forth on the continent. And all these guidelines were actually used to support our member state response to the COVID-19 pandemic. One other key lesson, as far as this COVID-19 pandemic response is concerned, is that critical importance of political leadership. Without that political leadership, there is no way we could have achieved most of what we achieved, notably that of equitable and affordable access to what I describe as security commodities, things like oxygen, things like personal protective equipment, therapeutics, vaccines, diagnosis. Without the support of our head of state and government, there's no way we could have achieved that. And as you can see on the screen then, at that time, our chair, when COVID-19 started in 2020 was Cyril Ramaphosa. And shortly after that, President Felix Sekete of DR Congo took over. And of course, our own chairperson at the commission, Faki Mahamat. All these were instrumental to the successful response of Africa CDC to the COVID-19 pandemic on the continent. Another key lesson is the importance of diagnostic, but much more importantly, the need to build local capacity. When COVID-19 struck, there were only 2 labs or 2 countries on the entire continent that could do or that could test for the SARS-CoV-2. These 2 countries were Senegal and South Africa. Fast forward, with the support of those 2 countries, with the support of our researchers on the continent, and with some international support, we were able to scale up, to the entire continent before the end of that 2020, through series of training at Institute Pasteur in Dakar and NICD in South Africa. Another key lesson is the importance to build our local manufacturing capacity for vaccines. Today, colleagues, ladies and gentlemen, of all the vaccines that are consumed on the continent of Africa, only 1% is produced locally. 99% is imported. There is no way you can guarantee our security this way. So critically, we need to begin to have that robust discussion on building local manufacturing capacity for vaccine on the continent. And there cannot be local manufacturing capacity without research and development, which further key into what we are discussing here today. Workforce development was also another key lesson. You cannot talk of research, be it acute care, be it clinical care, be it core public health issues without adequate workforce. In fact, one of the challenges, one of the critical gaps as far as health research on the continent is concerned is that lack of capacity. And what we have seen from our mapping is that that gap is quite huge. For instance, if you look at field epidemiologists at advanced and intermediate level, as a continent, what we need is roughly 6,000. What we have today is just 1,900. So look at the gap there. And this cut across the entire continent. Look at our frontline epidemiologists. These are people who are supposed to be at the community level. These are the people who call like surveillance assistants. These are the first point of contact whenever there is any emerging or re-emerging infectious disease. Today, what we currently have is 5,000. What we need is 25,000. So the gap is there for all of us to see. When you go to community health workers, the same thing. When you go to critical care capacity, it's even worse off. We did a mapping exercise at the onset of this pandemic. Apologies, I couldn't pull that. That slide before this particular conference. The gap is appalling. In fact, I used to use a phrase, one particular phrase when I'm talking to our political leaders, that some of our member states actually have more vice presidents, than critical care experts in their country. Should it be that way? No. So again, which underscored the importance of what we are doing here today. I also underscored the importance of capacity for research. So the COVID-19 pandemic also underscored the importance of critical care equipment, especially medical grade oxygen. And I'm sure all of us have seen the appalling data, coming out of the mapping, into what exactly do we have on the continent as far as these critical care resources are concerned. So again, Africa CDC is more than glad to be part of this, and we'll be more than glad to see what are the things that we need to do going forward to make sure that we build the necessary capacity as far as acute care on the continent is concerned. So let me shift there and try to focus a bit more on why we are here today. You all agree with me that just a few weeks after the COVID-19 pandemic, after the SARS-CoV-2, was discovered as a causative organism for the COVID-19, the genomic sequencing was released. And since that particular time, Africa CDC has continued to work with all the different research institutions on the continent to make sure that we put in place a very robust molecular surveillance capacity on the continent. And currently we're supporting 12 centers of excellence in Africa, including Capri, yes, that's in Durban, another center in Cape Town, and of course NICD. We continue to work in institutions like Ethiopia Public Health Institute, Cambridge in Kenya, Nairobi, the Nigeria Centers for Disease Control, the Institute Pasteur in Morocco, and so on and so forth. And for those members without this capacity, we also continue to provide some sort of remote assistance to them and facilitate the transport of their specimens to all these 12 centers of excellence. And we continue to organize different capacity building exercises so as to ensure that each and every member state is carried along as far as this molecular surveillance of different variants is concerned. So with this, we have been able to continuously monitor the SARS-CoV-2 mutations, which has huge implications on clinical care and by extension, huge implication on research. In fact, without that research, there is even no way we can pick some of these variants of concern. And of course, we continue to use findings from our molecular surveillance to investigate and inform our outbreak and response, to monitor how our diagnostics are doing, therapeutics, and much more importantly, vaccine efficacy. Again, we know that with the sequencing capacity that we are building on the continent, we have been able to use some of these to guide the development of treatment, vaccines, diagnostics, and other security commodities. Notably, the variant or the genomic sequencing results or findings have been used to develop monoclonal antibodies, some antivirals, and some of our diagnostic kits, not only in the global north, including on our continent. One is impressed by the good work that has been done in Morocco, where they've developed rapid diagnosis tech for COVID-19, so also PCR test kits with very rapid turnaround time. And for Africa CDC, we continue to support all these indigenous institutions to make sure that their capacity continue to grow from strength to strength. Again, vaccines have been a critical component of the response to this COVID-19 vaccine, the COVID-19 pandemic. And you will agree with me that there can be no vaccine without research and development. And while the continent continues to struggle, to move from 10% to 70%, surely, there will be a lot of cases coming to our healthcare facilities. For as long as we continue to see more cases at our healthcare facilities, we continue to see a lot of cases within the acute care setup. And for as long as we continue to see cases within the acute care setup, we need to continue to come up with evidence, to better guide our management of such cases, And we also continue to support member states to build their COVID-19 vaccine technologies, such as the mRNA And one is also quite impressed with a lot of advances that have been made within the couple of years, thanks to research, to accelerate what has actually dragged on for close to 25 years, and our ability to have been able to accelerate that in the space of 15 months. And on the continent, we continue to support the different clinical trial research sites, with many grants, with technical assistance, so that they are part and parcel of the COVID-19 vaccine development exercise. But much more importantly, to be able to sustain that beyond COVID-19 pandemic and use what we have gained now, the opportunities, the capacity that we have built now, to shift that needle from 1% of vaccine being produced on the continent of Africa to that of 60% come year 2040. So these are some of the achievements we've made as far as the vaccine landscape is concerned. And this is also thanks to a lot of research and development that's gone into this, from Senegal to Morocco to South Africa to Egypt to Algeria. And we continue to support other member states. Partners also continue to provide a lot of support as far as research and development on the continent is concerned. We have the MasterCard Foundation, who out of their generosity have provided huge amount of money, groundbreaking, unprecedented, first time in history, 1.5 billion to support Africa CDC efforts, on the continent. And a key component of what this fund will go into is to build research capacity on the continent, to support our institution, to build their capacity. And much more importantly, to also begin to regionalize our approach. We have all seen what the global mechanism can do, when they are challenged. Needless to say, to mention the fact that we are seeing colonization or recolonization of global health, including research. So what do we see as future of research? Health research, to be more specific, on the continent of Africa. We want to see a locally driven agenda or priority setting of health research. What do we mean by that? That whatever agenda or priority should, as much as possible, be locally contextualized. We want to see strengthening of capacity of our regional institutions, especially the academic institutions. We also want to see meaningful engagement of researchers, from low and middle income countries in all health-related studies and publications. So in terms of rethinking global health research agenda, we want to see involvement of our experts when it comes to setting agenda, when it comes to priority setting. Let's avoid a situation whereby what we see is a trickle-down effect, or what we see is something that has been determined as well, and we are just only implementers. Let's empower our colleagues locally to have the necessary capacity to be part of that agenda and priority setting. Let's also ensure that research is adequately financed. The science, technology, and innovation strategy for Africa, has informed our member states that at least 1% of the GDP should go into research. So let's see actualization, let's see implementation of that declaration by our head of state and government, to make sure that 1% of our GDP actually go into health research agenda. We also want to see focus on strengthening health systems, especially in low and middle income countries, because this is the only way we can sustain all the different programs, projects, initiatives, and so on and so forth on the continent. Let's get them institutionalized. One Health is also key, especially given the fact that more than 70% of our emerging and re-emerging infectious diseases are actually of animal origin. It's only through One Health that we can begin to have a comprehensive approach to things like surveillance and diagnostics, health diplomacy, communication, behavioral science, research ethics, emerging technologies, and research and development in general. The second approach from Africa CDC, or opportunity that we see, is to strengthen capacity of our institutions. And as Africa CDC, we continue to work with all these institutions. In fact, when you look at our operating model again, our engagement at the level of our member state are through the different public health institutions, including academia. So, colleagues, ladies and gentlemen, capacity building and training of local staff is key if you are to make any meaningful progress. 2, respected partnership and collaboration to advance knowledge and technology transfer is also very important. Funding, again, for point of emphasis, is key if you are to make any meaningful progress. So in terms of engagement, in health research agenda, we continue to build the capacity of our member states to ensure that whatever public health research agenda that is out there, we continue to lead from the front, especially when it has to do with research in low and middle income countries. It's our right to take the lead. And again, when we get all those studies carried out, we also want to ensure that we have a means of sharing our stories. We have a means of popularizing whatever or publicizing whatever we have been able to generate. Our data should be out there for people to see. And we continue to work with the different, peer review journals to ensure that our voices are heard. So these are some of what we published during the course of this COVID-19 pandemic. The aspect of COVID-19 vaccine, how to ensure Africa has access. These are myself, colleagues. The same thing on the issue of documenting what the first and second wave of COVID-19 pandemic in Africa has been like. So again, these are colleagues from Africa CDC and a colleague from different national public health institute. So, final takeaway, colleague. The COVID-19 pandemic has presented some challenges, especially in the aspect of research. The pandemic has affected data collection on the field. It has also shifted our focus from other diseases to COVID-19, despite repeated calls from Africa CDC and other international partners. Our study participants are not forthcoming for fear of contracting COVID-19. Research funding has been diverted to support other COVID-19 response. Some research sites have been repurposed for COVID-19 care. A good example is in Ethiopia, where one of the TB sites has been repurposed for COVID-19 treatment. The story is the same in other member states. We have also seen fragmentation of research approach, and going forward, we also know that the pandemic has presented a lot of opportunities. So as much as possible, let's capitalize on some of those opportunities. We know that the pandemic has led to renewed interest in public health and clinical research. For instance, let me give you an example. Before now, I'm not sure there's been any avenue for Africa CDC, to have direct engagement with our head of state and government. Today, we have had the privilege of talking to the African head of state and government 17 different times, to discuss this COVID-19 pandemic, to discuss how do we build back better and stronger, to discuss how do we begin to generate evidence to inform our own response locally. So colleagues, ladies and gentlemen, interest is there. So if you not capitalize on the interest now, if we do not make use of the opportunity that has been presented by this COVID-19 pandemic, then I don't know when we're going to get the listening ears, of our political leadership. The pandemic has also led to improvement in research collaboration. We have seen collaboration getting strengthened between Africa CDC, our WHO, Africa Academy of Sciences. We have seen a lot of interest. We've seen collaboration between Africa CDC, Addis Ababa University of, Stellenbosch, with in Joburg, École Nationale Santé Publique in Rabat, Morocco. So the pandemic has provided a lot of improvement in research collaboration. So we need to sustain that. We need to make use of the momentum that has been brought about by this COVID-19 pandemic. And of course, we have seen a lot of improvement in research and ethics, and Africa CDC continue to support capacity, and we continue to emphasize on the importance of regionalizing our approach, which further underscore what we are doing here today. So colleagues, ladies and gentlemen, before I round up, Africa CDC continue to advocate for a new public health order. This new public health order talks of the importance of strengthening our public health institutions, including academia. This new public health order continues to emphasize on the need for adaptive public health workforce. We need to continue to build our research capacity. We need to continue to build capacity for critical care, capacity for surveillance, and so on and so forth. We need to continue to build our local manufacturing capacity for vaccines, diagnostics, personal protective equipment, therapeutics, and other equally important health security commodities. And we continue to advocate for action-oriented respective partnership. That also key into what we are doing here today, because I can see a consortium of institutions, coming out of what we are doing for the past 2 days. Finally, it is crucial to keep an eye on the potential upsurge of COVID-19. We know there will be waves upon waves of this COVID-19 pandemic, but this should not be at the cost of public health or any health research, including acute care. Pandemics offer the only opportunity to carry out certain research. The pandemic has further underscored the need for more investment and better coordination in public health research. And for Africa CDC, we want to see surgery. We want to see global surgery as a core component, as a critical component of our public or of our primary healthcare system, because that is the only way we can guarantee the health security of 1.3 billion people and 55 member states. I thank you. Over to you, Jolene.
Thank you so much, Dr. Tajuddin, for sharing this work with us and everything that CDC Africa is doing around health research. We are running a little tight on time, and I don't see any questions, so I'll just put a call out to see if there are any questions before we move on. Okay, so we're going to move on now to our closing speech. And for this, I'm going to invite Dr. Salome Maswemi, and I hope I pronounced that correct. So if not, please do correct me. Dr. Salome is an associate professor and head of global surgery division at the University of Cape Town. She is World Economic Forum Young Scientist, a member of the Academy of Science South Africa, VP of Women in Global Health South Africa, and President of the South African Clinical Scientists Society, as well as being a board member of the Health Systems Trust South Africa. She specialized in obstetrics and gynecology and has completed postdoctoral research in Massachusetts and in Harvard, and has a certificate in leadership from MIT. She has received numerous awards for her research in maternal health, and we're delighted to have her join us today. So finally, I would like to thank you all for attending this conference, and I want to extend a big thank you to all of our speakers for your time and your contribution, and to our organisers for making this conference happen. We will end with a closing speech. Thank you very much.
Thank you so much. Really delighted to be here. I hope you can see me and hear me.
Yes, we can. Thank you.
Thank you. Firstly, I just put some slides together. I think I had the easiest job to sit and listen to everyone and put together some closing thoughts and remarks. And so I'll share my thoughts. But firstly, just to say huge congratulations to the organizing team first on putting together such an excellent program. I think what I really loved about it was bringing the different stakeholders together from the Ministry of Health, Africa CDC, the clinicians and people from different countries, researchers. And so I think it was a truly international, national and African conference all in one. So well done to the team. And also to congratulate all the speakers, not just on the excellent talks, but on the work that you've done. A lot of you presented a lot of research that you've done with the various networks, and that's really inspiring and encouraging. And what I liked was the consistent African theme around it, and everyone showing how they are collaborating, participating, partnering within the continent. But I thought I'd just touch on a few themes that I thought were important for us to take home and walk away with some recommendations. And so as stated very clearly, we know that this conference was about building African acute care research capacity as a priority in global health. And I think if you break it down, you've got a number of themes that come out of that. It's the research, it's the acute care, it's the global health. But I think most importantly for this conference, research capacity came out the loudest. And I think the important questions that we should walk away with is there research being done? And I think the answer is yes. A lot of research is going on, maybe not enough, but there is a lot of research that is going on. But who is doing the research? You know, are we simply collaborating, partnering? Are we collecting data? Or are we actually writing these research questions and leading these research themes? Who is asking the research questions? Are these national priorities or are these international priorities? And so important to figure out and to look at whether we're simply responding to what others are bringing in or whether we are actually writing down and are we the ones writing the research proposals? And who owns the data? Are the research collaborations equitable? Do we have the skills to do the research that we should be doing? Have we created an environment that will support the research that we want to do? Is there a balance between international research and locally driven research? Because it's so easy to get caught up in research collaborations and not do your own writing. And I think as Africa, we'll only move forward when we start writing our own research proposals. And then is this research reaching the policymakers? And with international research, it isn't always easy to get to the policymakers because it's not necessarily a national priority. It's a priority in the international scheme of things, but only us as locals can come up with national priority research that will interest the policymakers as well. And so important to mention, you know, who is looking after the sickest patients. And so I think that's where the whole part on critical care becomes so important because it's not the patients just coming into the system, it's what happens to the sickest patients. And we've seen with maternal mortality work that, you know, the patients that die are the ones that could not access the specialists, the critical care specialists, they couldn't get into an ICU. And so we need to relook how we're building the system so that we're not stopping halfway, but the sickest patients will survive as well. So what is the national strategy to increase capacity? Many have emphasized the what and the why. We should do what we do in the research, but very few go into the how. And that's how we stay behind because no one is telling us, not enough people are training us on how to do the actual research, on how to develop research teams, research institutes, etc. And so we stay behind as Africans because we're contributing to what others are doing, but not doing our own how. So it's important to figure that out and work that out. I thought I'd just share a snippet of my own journey from being an obstetrician, a frontline clinician, to being a clinician scientist. And so I realized as a junior doctor that, you know, I was limited. When my patients were sick, I didn't know what to do. I had to refer them, and hence I decided to specialize. But once I had specialized, I realized that, okay, now I'm looking after, I can sort out the issues in my hospital, but I can't sort out the population's issues. And that's when I moved into this journey of becoming a researcher, going into my PhD, postdoc, etc. But what I've realized is that as a clinician scientist, you find yourself having both the ear of the clinicians, the frontliners, as well as the policymakers. And I think as countries start to invest in developing clinician scientists, surgical scientists, and aesthetic scientists who will lead their own research and become experts, I think that's where we'll start seeing a big change in Africa. So investment in building African acute care research capacity is a priority. I think global surgery is one important way of doing this, because as global surgery, we not only look at the services that we're delivering, we look at the health systems, we look at the policies. And so I think global surgery is moving us into a new dimension where we can start looking at improving a system on all levels. And I think that's what we should all be starting to invest in. And so my recommendations, which have somewhat disappeared, are that we need to have a clear human resources for health strategy nationally. You know, we shouldn't leave it to chance. We need to know how many specialists do we need? How many critical care intensivists do we need? That needs to be part of the national plan. We need to invest in clinical and research capacity, research infrastructure, and protected research time. It's one thing to say, let's do the research, but if there's no investment time or infrastructure, we're setting people up for failure. And lastly, we need a strategy to develop a pipeline of health African experts, the next generation of academic scientists, professors, to lead research on national priorities and inform policy that will contribute, and people that will contribute to the global health dialogue. So I hope you have all been inspired by this conference, and I hope that as we go along, many of you will be looking at not just doing research, but becoming surgical scientists, influencing policy, influencing care, and ultimately having Africans who are sitting on those tables and feeding into what the world should be doing. So thank you very much to all of you, and I'd really like to wish you all a great day ahead, and kudos to the team. And we look forward to having another conference like this in the future. Thank you so much. Okay, and that brings us to the end of the conference.